Good afternoon, everyone. Assalamualaikum. Welcome to our 14th session of this recall-based discussion. Today we have these list of topics. So let's start with the first one, that is Hinoxian line purpura. So let me take you to the MTB 448. Okay, so it's one of a kind of vasculitis more frequently seen in children. So most of the time for MCQ, for the basis of MCQ, we will see the age of the patient. So mostly we'll find children, mostly 5 years or more than 5 years of age. And it's one of the kind of vasculitis where we will see there's involvement, because if it's vasculitis, there are chances that the bleeding may occur. So if it's an intestinal bleeding, gastrointestinal bleeding, we will see it may occur with the pain or bleeding, how the GI bleeding will present. The baby must be having melena, this black stools, so that we can give, it will give us a clue that it's a GI bleeding or it's a lower GI bleeding. If it's upper GI bleeding, then of course we'll find hemoptysis, or we will find this hematemesis, maybe vomiting is there. But most of the time it's difficult in children, to distinguish between hemoptysis and hematemesis. But of course, as far as the GI is concerned, we will say the term hematemesis, and that's the main cause here. Then we will see on skin. So the skin of the children are very fragile. Whenever they are having this Hinoxian line purpura, we will see this blanching of the skin. Just beneath the skin, the vessels, which are superficial vessels, they're very prone towards fragility, and they just, they will become fragile and they will distort, they will start bleeding, and that blood is going to accumulate it just beneath the skin and causing this purpura. This is a chymosis that is just beneath the skin. We will find collection of blood. So if there is collection of blood just beneath the skin, the term is known as purpura or chymosis. So that is very most common presentation in these children. That will give you a clue that it's one of vasculitis. Then of course in joint, the babies will show arthralgia. That's if the baby is big enough, he can say you the pain is there, it's okay, but we can see hemarthrosis as well. But please remember that hemarthrosis is not the feature of Hinoxian line purpura. Most of the time we will not see any kind of bleeding which is going to be inside the joint, and that's appreciable. We will not see a hemarthrosis. We will usually see in the patients of hemophilia, where there is too much amount of bleeding as compared to the normal one. Because in this Hinoxian line purpura, we have actually vasculitis. There is nothing like decreased amount of platelets. So whether the bleeding is there or not, the severity will not be too much. But once we are comparing this henoc with the hemophilia, then hemophilia children may present with hemarthrosis, because there is a lot of bleeding because of the decreased amount of platelets, because of the decreased amount of clotting factors. There we are deficient with the 9, 8, and 7 clotting factors. So of course, because of the deficiency of the clotting factors, the bleeding will be much more as compared to just vasculitis, where it's only a distortion of the blood vessel, and blood vessel is damaged and the blood is coming out from the blood vessel. So you can imagine what kind of bleeding will be there when the hemophilic children is going to present in front of you, or when Hinoxian line purpura comes to you. In hemophilia, there will be much more bleeding. So in joints, hemarthrosis, if it's a presentation, always think about hemophilia first, because joints is very much, deeper organ structure, highly stable structure. If that is hemarthrosis is there, bleeding is accumulated inside there, that must be a factor where we can think about hemophilia, just not this Hinoxian line. But arthralgia is one of the things. The joint pain can be the reason, but you cannot very much appreciate whether there is bleeding inside the joint or not. Then renal, of course, hematuria we will see. So you are seeing that multiple sides the bleeding is there, and GI bleeding is there, beneath the skin is there. Renal hematuria can be a presentation. So this Hinoxian line purpura is most often a clinical diagnosis. However, biopsy is the most accurate test when we exactly come to know, okay, the cause is only the vasculitis, because we won't find anything on CBC, don't find anything on lab investigations. Now, when the case described leukocytoclastic vasculitis on biopsy, the answer is Hinoxian line. So leukocytoclastic vasculitis means that all the cells which are inside the blood vessels, they are actually going to hemolyze. There will be hemolysis, there will be lysis of the blood vessel cells itself, then the endothelium of the vessel wall is going to be damaged. So that's that's a feature that we can only find on biopsy. But these children, their presentation is very much common. in a way that you will find there as such no cause, but you will find inflammation all over the body, and multiple sites are showing ecchymosis, multiple sites are showing purpura, and you will see sometimes hematuria, sometimes this black stools in history. So and nothing else, all the investigations and lab investigations are normal, then you might think about HSP. Now, what treatment you are going to offer? Most cases resolve spontaneously. Steroids are the answer for severe abdominal pain. So most of the time we don't do anything. It will go by themselves. Whatever the collection is there, it can be easily removed only with the help of these macrophages and neutrophils. But sometimes we may need to give steroids as an anti-inflammatory or the answer for severe abdominal pain or progressive renal insufficiency. So if there is too much involvement of the kidney, there is too much involvement of the GI system, then only we can think about giving this steroid. Steroid anyhow will give for a short period of time. It will act like a magic. It will, just do the anti-inflammatory effect. Steroid do not reverse the renal insufficiency, but may decrease the progression. So it's going to stop the progression. Of course, whatever the damage is there, it will remain there. We cannot change that damage, but of course, further progression can be stopped. Now, serum Ig levels are the wrong answer. They are not reliable when testing for NOx. So, of course, will not go for any immunoglobulin. It's not an autoimmune disease. It's just a vasculitis. There, we will see the inflammation of the vessels and the hemolysis of the vessels occur. There will be a bleeding. And that bleeding we can easily appreciate in the form of purpura. That bleeding we can easily appreciate, especially in form of hematuria or maybe melena. So if you just look at the question. Here the question says, a 4-year-old boy, so look for the age of the patient. Here is he's 4 years old with a 1-day history of abdominal pain and vomiting. So abdominal pain is there, but it is also associated with vomiting. He was afebrile and has no diarrhea. So vomiting which is not accompanied with the diarrhea, that will give you a clue. Okay, it's not something infectious in the body. He has bilateral knee pain. He's complaining of knee pain. 4-year-old boy, he can appreciate the pain. And there was some tenderness of the knee joints, but no effusion. When you check by yourself, you can easily feel the tenderness over joint. But as such, there is no effusion, there is no hematorosis. Within 24 hours, he developed a rash on his legs and buttocks. So on presentation, he was just having an abdominal pain. He was just having this knee joint pain. But later on, within 24 hours, the presentation now has changed. Now he's developing a rash on his legs and buttocks. That's a purpura, which is petechial and purpuric ecchymosis is there. Beneath the skin, superficial bleeding is there. And his platelet count was normal. So that will again give you a clue that if the platelet counts are normal, it means that the baby is not having any ITP or TTP or any kind of bleeding disorder. Then what would be the choice? Now, which of the following is the most likely diagnosis? So what you're going to think? Do you think it's a SLE? Of course not. SLE is an autoimmune disorder, and SLE presentation should be very much starting from the skin with the malar rash. So if there's a particular cheek rash, butterfly rash on the skin, that is the most important clue where you can diagnose. Although autoimmune disease and all the organs must be, there must be 7 to 11 presentation in the case of SLE, not just only this one that he's having pain in the joint or he's having petechial or purpuric rashes on the skin or buttock of the legs, buttocks or legs. So for making a diagnosis of hemophilia, we have to have at least 4 or 5 criteria out of 11 criteria where we can say it's a SLE. We cannot say here it is he's SLE. And anyhow, in order to make a definitive diagnosis of SLE, you have to have ANA result, you have to have lab results with you, you have to have this, especially those other profile, which actually going to confirm that, yeah, this is particularly SLE. So we have to think about that one. So of course, we will exclude this SLE. Hemolytic uremic syndrome plus TTP. So TTP and hemolytic uremic syndrome, there must be, of course, diarrhea will be there because the presentation is Shigella and E. coli. They are responsible for this one. Here there is no diarrhea, one of the most important thing. And secondly, in hemolytic uremic syndrome, you will always see decreased platelet counts. And here it's clearly mentioned that the child is having normal platelets. So that's again, you can easily rule out on the basis of platelet and on the basis of presentation of the symptoms like diarrhea should be there in order to make a diagnosis of hemolytic uremic syndrome or TTP. Then we have Kawasaki disease. Kawasaki disease, again, it's one of the kind of vasculitis, but it's again autoimmune disease. So you can just not, say on the basis of only presentation, you cannot diagnose this as a case of Kawasaki. So based on the symptoms where all the lab investigations are normal, only because of the presentation, you will go for Henoch-Schönlein line purpura.
And Dr. Hera, in Kawasaki, the patient should have fever. He should be febrile.
Yes, exactly.
Febrile.
The presentation is just like infectious disease, exactly. And here there is no fever. Very good. That's again a clue. Then we'll go for the theory first. I will go for ITP, idiopathic
Dr. Hira,
thrombocytopenic purpura.
Dr. Hira,
Yes,
please
dear.
थोड़ा सा hemolytic urine syndrome repeat कर दें.
Hemolytic uremic syndrome we will going to cover in detail, so don't worry. Just now, just think about that in hemolytic uremic syndrome, there must be a presentation of any infectious diarrhea. Say, for example, E. coli and Shigella. These are the two most important organisms that is going to cause diarrhea in a child. And then the presentation will be, of course, just like the same presentation, but here the platelets count will be decreased. In HSP, there is no platelet count. You will not find any thrombocytopenia. But in especially in hemolytic uremic syndrome, and the another type of this hemolytic uremic, we have this TTP. Both of them should have decreased level of platelet count. So that is only a difference where you can differentiate. Anyhow, the presentation mostly the same. In both of these cases, you will see there's purpura and everything, but based on the platelet counts, you will say normal platelet count, then it must be a Henoch-Schönlein line. But if the platelet count is decreased, think about hemolytic uremic syndrome. So just now, just memorize this one, and later on we'll go to hemolytic as well. We will going to cover today as well, so don't worry. Let me take you to ITP first. Slide 16. Okay, so it's of course ITP, idiopathic thrombocytopenic purpura, is one of a kind of bleeding disorder. So which make you a help you in making a diagnosis. What is the most likely diagnosis? You will always look for isolated thrombocytopenia, in which it means that there will be no changes in the RBCs, there will be no changes in the WBC count, but only isolated, only thrombocytes, you will find them, only platelet count, you are going to see that they are decreased. Normal platelet count is in between 150 to 3 lakh. So if it's below 150, so you will say it's an isolated thrombocytopenia. So one of the most important point in ITP, you will go for the investigation, you will look for the lab test, and only isolated if the platelet counts are low, then you can think about ITP. And normal size is spleen. See, this is very important, because most of the bleeding disorder, when we don't have normal cell shapes, the spleen is actually the one who is suffering, and we will see splenomegaly in all of these blood disorders, bleeding disorders in patients. But here in this case, of course, there is deficiency of platelet, but whatever the platelets are there behind, they are absolutely normal, and they will not cause any damage to the spleen. While in other bleeding disorders, what usually happen, if there is deficiency of some kind of cell, so the other cells which are going to produce, they are actually immature cells. They come in circulation just in order to compensate the demand of the body. And what will happen, the spleen has to work a lot, because a spleen is never going to allow those cells which are immature to be in circulation. So what will do, spleen has to capture all those cells, and there will be a splenomegaly, and we will always find splenomegaly in that case whenever there are immature cells in the circulation. But here in this case, there is thrombocytopenia, but we will not see megakaryocytes coming in the circulation, because megakaryocytes are the one which is going to convert into mature platelets. And as the name indicates, megakaryocyte is a big cell. Once megakaryocyte is in the circulation, the spleen must have to capture those megakaryocytes. But it means that although we have deficiency of platelet, but megakaryocytes are not coming into the circulation. That's why spleen is absolutely normal. There is no megaly in the spleen. So that is again one of the clue in making a diagnosis of ITP. You will not find any kind of splenomegaly in these patients, and you will only see decreased amount of platelets. Now, how you're going to diagnose? Yes, dear.
Sorry, how to differentiate ITP from HSP?
From HSP, Henoch-Schönlein line. In Henoch, there is vasculitis. There is actually damage to the vessel wall. But in ITP, there is only decreased amount of platelet. And think about what if the platelet count is decreased, what will happen? So if the platelet count is decreased at any point of time, what will happen? The patient may bleed, and the bleeding time will be much more as compared to the normal person. So if, say for example, if one is having ITP, he is having more bleeding and clotting time as compared to the normal person. He bleeds a lot. Most just you are going to you are applying pressure on the skin, maybe his skin can develop purpura, or maybe if he start brushing, the bleeding is there, gingival bleeding is there, and it will become more and more, and it will take time to stop as compared to the normal person. Or if there is any history of fall, you will see more and more bleeding as compared to the normal person. So but in case of henoxian line purpura, that's totally different picture. That's a vasculitis. In vasculitis, so all over the vessels, especially in the GI, or especially in the renal, or especially all over beneath the skin vessels, they may bleed anytime, because there's a vasculitis infection, inflammatory infection, and that inflammatory infection is not owing because of the infection. That can occur at any time. Rather, we cannot say it's a autoimmune, not an autoimmune infection, not an infectious infection, infectious based infection. There is no as such
So there
etiology.
will not be increase in thrombocytes or decrease in
Yes,
thrombocytes.
in henoxian line purpura, platelets will be absolutely normal. While in case of ITP, that the whole plays around the platelets, that the platelets will be decreased, and you will not see abnormal platelets called megakaryocytes in the circulation. Just in order to compensate the demand of the body, megakaryocyte will not come in circulation. That's why you will find normal spleen. Otherwise, once megakaryocyte is in the circulation, just in order to compensate the demand of the body, the spleen has to work a lot, and there will be always megaly in this spleen. But here in this case, there will be no splenomegaly. So that's again one of the clue for you. And in henoxian line purpura, always platelets count will be normal. There has nothing to do with the platelets. They're in henoxian line. Only the blood vessels are the one which are very fragile, which can easily rupture and bleed outside, and that bleed under the skin can call purpura. So most of the time the presentation is like purpura. But here the purpura is there. Why? Because of the decreased amount of platelets in IT.
So here will be megakaryocyte increased, huh? Circulation.
No, megakaryocyte. Why? That's the whole point. In ITP, there will be no megakaryocyte in the circulation. That's why the spleen is absolutely normal. There is no megaly in the spleen. Platelet count is low, but bone marrow is not working hard in order to push this megakaryocyte. Those are the immature cell into the circulation. So based on the normal physiology, that's why we are saying it's an immune thrombocytopenic purpura. Your bone marrow is not producing immature cells and not releasing actually immature cells into the circulation. But in other type of bleeding disorders,
Hira, if you see the slide you are showing, just the megakaryocytes are elevated in number. That's why I said like this.
See, megakaryocyte numbers are elevated because when you do the biopsy of the bone marrow, you will see megakaryocyte, because megakaryocyte are the precursors for forming platelets. But megakaryocytosis will not be there. Like megakaryocyte will not be there in the circulation. There are two different things. The one thing is the cells are going to form in the bone marrow, and when you check the count, like in normal cases, you will always see erythropoietin, which is a glycoprotein for the erythrocyte, 1 to 2%. But when there is demand, you can see 40 to 45%. But that is only up to the bone marrow. So once you do the examination of the bone marrow, ultimately you will see megakaryocyte increased number, but they are not going to be released into the circulation. So that is a different part. Circulation is a different part, and being in the bone marrow and forming a mature platelets, that's a different thing. Are you getting me? So here, how we are going to diagnose these patients? Idiopathic thrombocytopenic purpura is a diagnosis.
Yes,
so it's a diagnosis of exclusion. First, we exclude any other thing, and then you can think about it. Now, antiplatelet antibodies lack specificity, limited benefit. So, of course, it's not in here. We will not see any kind of antigen antibody reaction. So, antiplatelet antibodies also, this test will not going to help you a lot, because here the platelets are not deficient because of antiplatelet antibody. There is no acid antigen antibody reaction, and that antigen antibody reaction actually causing this platelet. That's something related to immune system. That's naturally the platelet counts are low. We won't say that the platelet counts are low because there is antigen antibody reaction. That's why platelet counts are destroying. No, it's not like that. Ultrasound or CT scan to exclude hypersplenism. Of course, we will see either spleen is working here a lot or not. That will give you a clue. So on palpation, usually spleen is palpable, but whether you want to see there is hypersplenism or not, you can go for this testing. But usually we don't have any this kind of finding. Megakaryocytes are elevated in number, but they are not going to coming in circulation at all. Bone marrow not routine indicated only before splenectomy. If we really need to go for, go for the splenectomy because of any reason, but here we don't have this splenomegaly finding, so there will be no need of a splenectomy. But in case if there are the things we have to go for that, we will not prefer, this kind of bone marrow biopsy or bone marrow examination, because presentation is quite clear. But once we have to go for the any kind of procedure, then only we have to evaluate bone marrow first, then only you will go for splenectomy. If bone marrow is not working fine, removing the spleen will not help the situation. Because why? Because once you remove the spleen, then of course there will be no one to to take care or filter any kind of abnormal cells or immature cells which are released from the bone marrow. So the bone marrow has to work properly. Once you are done with the bone marrow examination, then only you can think about, okay, if there is too much hypersplenism or something is happening, we can just remove that part, because bone marrow is working fine. This is the spleen who's catching things faster as compared to the production inside the bone marrow. So these bone marrow and spleen, they are actually having a check and balance mechanism. Whatever the bone marrow is producing, spleen has to normalize and regulate the whole thing. That's the duty of the spleen, that normal kind of cells should be in circulation, and that's the duty of the bone marrow to produce the normal kind of cells. But of course, in bone marrow, there is a whole process of formation of this RBCs, WBCs, and this platelets, because there are the cells which are actually going to take a whole process, and they are going to convert into from immature to mature cells. Just like reticulocyte are the immature cells, RBCs that are immature, and reticulocyte should not come in circulation. Only in normal condition 1 to 2% reticulocyte count can be there, but once it comes in circulation, after 1 to 2 days, the reticulocyte has to be converted into a mature RBC, that is a biconcave disc-like and non-nucleated one. Similarly, WBCs, that will a whole procedure, in order to make this WBC. There are different stages by which we will see this WBCs are mature WBCs are actually formed. And not only WBC has a variety of cells. Some are getting granulated, some are non-granulated, like this basophil mast cells, basophil and neutrophils and eosinophils, and we have this lymphocytes and the other one, T cells. So lymphocyte B and T and this monocyte. So there's a list of cells, and bone marrow is responsible to form the mature cells. But of course, the whole process is occurring in bone marrow. So in order to do anything, first we need to examine bone marrow. But they are saying in this case, in this ITP, bone marrow is the last resort to check. You can check bone marrow, you can go for the biopsy, but do it at the last. Increase in mean platelet volume. So whatever you will see platelet count here, that also is having a increase in mean platelet volume. But it's not like that they are the megakaryocytes. Megakaryocytes are not coming in circulation. Whatever the platelets are there, they are actually increasing in size. It means that megakaryocytes are converted into platelets, but again, the formation is not normal than routine. Like in routine, the megakaryocyte should be converted into a proper platelet. But here the platelets, those we will find in ITP, they are actually having a mean volume size increase. It means that they are the platelet, but they have some morphological disturbance, like morphological findings is there. No, morphology is not normal in case of platelets, which are found here in ITP. And what else is there? There will be decreased platelet count. So what we are going to do? So if there is it depends on how much the patient is bleeding. If there is
Dr. Hira, sorry to interrupt you. Increase mean platelet volume here means that only the cellular volume is increasing, not the whole count of platelet.
Yes, only because whole count is decreased, right? Whole count overall is thrombocytopenia. So that's an individual platelet which is actually in the circulation, which you cannot say it's abnormal platelet. You cannot say it's a megakaryocyte, but it's morphological difference is there. Like there is some morphological change in the platelets. Amount is also decreased and change. And what change is this? The volume overall you can see increased. Yes. Now we have this treatment. treatment part. Okay, so here we will see the amount of bleeding. So if there is no bleeding at all, and you will check the platelet count, of course it's more than 30,000 but less than 150, which is a normal value, then we will not go for any treatment. Of course, if there are no symptoms, we will not do anything. The answer is simple as that. But if there is mild bleeding, and once you check the this platelet count, that platelet count is less than 30,000, we will go for glucocorticoids. This is important, not for the recall point of view, but of course for your clinical point of view. And of course, we are not only concerned about the recalls, we can find any kind of MCQ in front of us. So please memorize this one. This is very important. So if the platelet count is less than 30,000 and patient is symptomatic as well, the patient is bleeding as well, always think about glucocorticoids. Now, if in case of severe bleeding and the count is very much low, how much, like less than 10,000, then we will go for immunoglobulin. So most of the time we will just confuse in between when to start glucocorticoid and when to start immunoglobulin. In order to start immunoglobulin, the patient has to have the severe bleeding plus count is very much low, below 10,000. But if count is less than 30,000, and there is 1 minute, yeah. Okay, sorry about that. So if there is a severe bleeding, the count is less than 10,000, we will go for immunoglobulins. Then recurrent episodes are steroid dependent. Now the thing is happening again and again, and then now the patient is dependent on this glucocorticoids or steroids, then we can think about splenectomy, because splenectomy is the one who is going to catch, or if there is no proper catching, then we can go for splenectomy. Then splenectomy or steroids not effective, then what we can do, then we have other medications, say for example this romiplastim and rituximab. These are anti-cancer drugs. They are working as anti-cancer drugs, cyclosporine as well. We can give this one. They are actually going to work on bone marrow. So that's what we can use, but that's the last resort. Always keep the bone marrow things at the end in case of ITP. So platelets are large in ITP. We have already seen
Hira?
that the mean corpuscular volume is increased. Yes, dear.
Why splenectomy?
See,
There was
why?
not we did not have increased number of
But we
megakaryocytes.
have platelets which are more than in size, and because of we have this not normal morphology of platelets. And what should be the function of this spleen? The function of this spleen is to capture those things which are not morphologically normal. That's the main function of the spleen, right? Spleen is acting like a sieve. So it should be, it should capture all the cells. Sometimes it's capturing this platelet also, which is having this big size. Sometimes, and hypersplenism you can also find in these patients. And sometimes the spleen, it's not working at all, and only there will be so much, autoimmune reactions happening inside the spleen. Too much, because the spleen is the main thing which is going to capture, and there is so much antigen antibody reaction happening in the spleen, because spleen is one of the lymphoid organ, right? So sometimes we are seeing that these abnormal cells are in circulation. There too much autoimmune system is working inside the spleen. In that condition also we have to remove the spleen, because the spleen is one of the lymphoid organ, and there is too much autoimmune reproduction, you can say autoimmune production, or antigen antibody complexes are forming inside the spleen, which are actually going here and there and causing problem. So what we can do, we can, in that situation also, we can remove the spleen. But most of the time we will not find splenomegaly, but we will find hypersplenism. Hypersplenism is the one, like this spleen is going to capture the normal cells plus abnormal cells, like the one here. Here the platelets are platelets. They are not megakaryocyte, but they are having little increased size cell. So what will spleen will do? Spleen, if it's going to capture these platelet, again you will find hypersplenism. If it's too much, you have to remove the spleen. Otherwise, the normal functioning of the spleen is going to be disturbed. Then it will not focus on the function itself. It will just keep on, busy in collecting these all abnormal platelets. So you're getting my point, because spleen is one of the major lymphoid organ that has to capture all the unwanted things, not only RBCs, not only WBCs. Spleen has to capture everything which is unwanted in the blood. So think about if the focus of the spleen is disturbed, or if something is getting inside or stuck in the spleen, then what we will do? We have to remove it. But otherwise, there will be too much antigen antibody reaction in the spleen.
Then we will not be having the protective effect of spleen.
It's exactly. Other than that, we will have autoimmune effect in the whole body. The whole body started to know who our antigen is going to, our own antibodies is going to destroy every our own antigen. So that is, autoimmunity will, autoimmune function of the spleen is it's become very functional. And then the spleen will not be able to distinguish whether it's our own antigen or it's an outside antigen. Again, this thing. So, but whenever we are considering removing a spleen, that is also again a last resort option. So think about that the spleen is actually protecting our body from the various infectious agent. So what we have to do once we are deciding that we have to remove the spleen in some patients because of any reason, because of too much splenomegaly, because of too much autoimmune reaction, because of too much hypersplenism, because of the dysfunctioning of the spleen, then we will think about giving vaccination to the patient, those patients in which we are actually planning for splenectomy. So this Neisseria infection, that's one of the great infectious agent. Hemophilus influenza, pneumococcal is one of the lethal infectious agent. So we have to vaccinate the patient prior prior to splenectomy. So whenever you are thinking about removing the spleen, you have to vaccinate the patient, because you are going to remove the one thing which is going to take care of all these things. So once this is not there, at least you should vaccinate the patient, so that the patient must have immunity, antibodies in the body. And then once these infection can come, there will be much more secondary immunity. The body can provide much more secondary immunity as compared to primary, because once the new infection is coming in our body, it will take some time to develop antibodies, to protect that infection. That's why sometimes for the first time the patient may contract disease, but the second time when the same infection is coming, we already have antibodies in our body, and there will be too much antigen antibody reaction, and the person will not suffer a lot. But once you remove the spleen, you have to have, although the patient never suffer any pneumococcal infection during his whole life, but who knows, maybe the patient can contract anytime. So we have to vaccinate the patient prior removing the spleen, so that the patient at least can develop secondary immunity, at least have antibodies already prepared in his body, so that once the pneumococcus is there, the reaction could be great and the patient will not suffer a lot.
Okay, thank you.
So let's have a look at the questions. Here the question is saying, a 5-year-old child presents with bleeding from the nose and gums and easy bruising of the extremities for 3 days. Now, just a history of 3 days, and it's not followed by any kind of infectious thing. Nothing is there. Only the question is saying the patient is having nose and gum bleeding and easy bruising. So which of the following is the most likely diagnosis? What do you think? Do you think it's a idiopathic thrombocytopenic purpura, or it's a Hinox-Schönlein line purpura? See, in order to make a diagnosis of Hinox-Schönlein line purpura, there should be a vasculitis concerned bleeding, and it should be purpurous. It's not about like nose and gums bleeding.
There should be abdominal pain and
abdominal pain, exactly. There should be melena, and there should be hematuria. The presentation is not like the oral and buccal cavity, bleeding.
The system will be chronic.
Arthralgia is also in case of
exactly. What about this meningococcemia? Meningococcemia, the other name is blood poisoning, where the blood is leaking. It bleed like a hell. Let me show you one of the picture of this.
Blood poisoning or meningitis?
No, meningococcemia. The another name for meningococcemia is blood poisoning. Blood poisoning in the sense, you will see once the bleeding is there, it will be too much. I just wanted to show you one picture. See, like this one. Do you think it's a Hinox-Schönlein line? Hinox-Schönlein line is just a purpura. It's just a purplish skin, which is showing that some of the superficial vessels, they actually bleed. But here you can differentiate. This boy is having too much because of meningococcemia. You can see the whole bleeding, and the bleeding is too much severe that it's not stopping at all. It's continue to bleed, and the appearance is like this one. Can you appreciate? There is too much bleeding.
Yes.
So of course in meningococcus is the one who can cause meningitis as well. But the vasculitis, if you are considering owing because of the effect of meningococcemia, then think about the bleeding, which is bleeding like a hell. Like the whole body is going to get changed into the red thing. It's not just a purpura or a chymosis. It's a whole blood. You can see like the thing is wholly covered with the blood. Only blood is there, nothing you can find in the tissue. So of course, it's not a
Okay,
representation of meningococcinemia. Hemophilia A, always think about for hemophilia. It's not about the one episode of hemophilia A. Those who are having hemophilia, they used to have this easy kind of bleeding, and there must be a history of recurrent bleeding. It should not be like this, that the patient is only having 3 days history. No, the one who is having hemophilia right from the very early age, right from the congenital, it's a congenital thing. So right from the beginning of a child's age, you will find that the child is more prone to have bleeding a lot. So once the gums bleeding is there, it will keep on. So it's a recurrent thing. It's not just with the history of 2 or 3 days, but sometimes we are saying this was only a presentation of 3-4 days and it's just started in 5 years or 10 years. Then you can always think about idiopathic or immune thrombocytopenic purpura. And of course, you cannot say it's a hemophilia because you don't know exactly. You should know what kind of clotting factor is there. So never ever think about anything which has, something lab investigation or some workup should be there in order to make a definitive diagnosis. Whenever the question is asking what provisional diagnosis you have in your mind, then only we can have this option in our mind. Okay, maybe hemophilia is there, but there should be recurrent history in the child. There should be hemophilic factor, hemophilia, clotting factors. We will see on the lab investigation which kind of clotting factors are missing here. So then only we can say, okay, in order to make a provisional diagnosis, I can think about hemophilia. But whenever the question is said, which is the following most likely diagnosis, it means that the patient, the question or the examiner wants you to think about the one where we will think about that, okay, it's a definitive diagnosis. So of course, in order to make ITP diagnosis, you have to have only the symptoms presentation. You don't actually need as such lab workup. Yes, we may find a lab workup. We have to see the value of the platelets, but that's okay. That's a normal CBC lab normal investigation. We have nothing special to rule out. Nothing is special to rule out in terms of autoimmune antibodies, in terms of any clotting factors deficiency like that. And of course, the presentation of hemophilia should be having recurrent symptoms. It should not be the history of 2 or 3 days. It should be right from the beginning of the patient's life. If you are considering hemophilia, so that's a clear case of ITP. Okay, so now for the next one, I think we should go for the theory first. So we have this hemorrhagic disease of the newborn. These hemorrhagic disease of the newborn, they are very easy to diagnose. Their questions are very easy. What we will usually see that the child is delivered recently and should be delivery at home, because once the child is delivered in hospital setting, we usually give vitamin K just after birth of a child. Vitamin K has to be given intramuscularly just after the birth inside the labor room. In fact, inside the labor room, the nurse has to give. But of course, when we are thinking about delivery who is occurring in the hometown or in the house, or of course, such kind of deliveries where they don't have any facility of this injection vitamin K
Dr.
at
Hira,
home.
excuse me, Dr. Hira, the screen is not okay.
Screen is not okay. 1 minute.
Yeah, it's
I
hanged.
actually need to see which page number is this one. And page number check, it's 826. Let me know now if you can see now. 826. Okay, now can you see vitamin K bleeding?
Yeah, I can see it.
yes, we can see now.
So it's actually what I was telling you, that for these type of questions where we can think about this hemorrhagic disease of the newborn, as the name indicates, it's actually two things. One is called vitamin K deficient bleeding, and the other synonym for the same term is hemorrhagic disease of the newborn. So there is no difference if you want to say vitamin K deficient bleeding, or if you want to say hemorrhagic disease of the newborn. So as the name indicates, newborn, so just after the delivery of the baby, if the baby is not going to receive vitamin K, then what will happen? They will be bleeding. They will be bleeding like the umbilical cord is going to bleed, or when you're changing the diaper, you will see the rectal bleeding. So that always think about these hemorrhagic kind of questions. So here it says, as the neonate colonic flora has not adequately colonized E. coli, is not present in sufficient quantities to make enough vitamin K. So these are the useful bacteria actually inside the gut. They are responsible for the formation of vitamin K. But of course, as the newborn, neonate, new engine, it doesn't have too much kind of this E. coli colony or this useful bacteria. So they actually are not capable. These newborn babies are not capable to produce these clotting factors, especially And we know very well what kind of clotting factors which are dependent on vitamin K. They are 2, 7, 9, 10. 2, 7, 9, 10 and protein C and protein S. 2, 7, 9, 10 are the clotting factors. And these are the clotting factors which we say these are actually vitamin K dependent clotting factors. If there is no vitamin K in the body, these clotting factors will not be formed. 2, 7, 9, 10 and protein C and protein S also. And if these clotting factors are not going to form, then think about there will be no, once the bleeding is there, they will keep on bleeding. There will be no clotting at all. So just in order to have this clotting mechanism, these clotting factors should work properly. And these clotting factors are dependent whether they have to produce from the liver or they are dependent on vitamin K. So if they are dependent on vitamin K, think about only 4 factors: 2, 7, 9, 10 and 2 proteins, protein C and protein S. So in newborns, when there is no vitamin, if you are not going to give vitamin K to your newborn, then what will happen? Because the newborn cannot prepare vitamin K by itself, because the newborn doesn't have this E. coli. So he has to have this later in the life. He will have this lethal bacteria in his gut. Then there will be no problem. But soon after, but he doesn't have. So that's why the vitamin K is not there, and 2, 7, 9, 10 will not be there. Clotting will not be there. So once the bleeding is there, it will keep on bleeding, or it will take a lot of time for clotting. So here you will say, without such factor, the newborn is more likely to have bleeding from the GI, belly button, urinary tract. So think about every possible thing from where the blood can come out. So urinary tract, in fact, this rectal bleeding, this belly button bleeding. Why belly button? Because that's a so that is more prone towards bleeding. So what we will give to prevent these type of diseases, we have to give single intramuscular shot of vitamin K. And of course, those babies who are delivered at home, they don't have facility of vitamin K. Those babies are more prone towards this hemorrhagic disease. And in the hospital setting, as soon as the baby delivered, that's the duty of the nurse to give this vitamin K injection as soon as after the birth of the baby. Now, anything that decreases mortality is most likely to be tested now, of course, in this type of questions. So let's have a look at the questions. Here the question is saying a 5-day-old infant was delivered. Now he is just 5-day-old, was delivered normally at home. So once home delivery is mentioned, always think about hemorrhagic disease of the newborn. Attended by a midwife, he had never been to a hospital. But now, know that we have bleeding from the umbilical cord that seems increasing in severity. The bleeding is getting worse and worse. He has been breastfed since after delivery. The mother had a normal perinatal period but was diagnosed with epilepsy 10 years ago. This thing is just there to misguide you or to give you a trouble, but it has nothing to do with the question. Even though if the patient is epileptic, even though the patient is on anti-epileptic drug, that is not going to cause problem in the baby. That's why we keep on continuing this anti-epileptic drug in the pregnancy as well. And has been taken phenobarbital. So we'll not think about this one. For, of course, if the patient is taking phenobarbital, you will just guide them about the breastfeeding thing, that she can breastfeed the baby after taking this phenobarbital 2 hours after taking this phenobarbital. That's the only thing we can guide as far as this phenobarbital is concerned. Now, test result: normal values, bleeding time 3.8, prothrombin time 21. APTT 46. So APTT slightly raised, prothrombin time of course raised. So you can see this clotting time, all the clotting time is raised, and bleeding also, bleeding time 3.8 up to 4 minutes is normal. So he is bleeding actually normally, but because of the deficiency of the clotting factor, the clotting time is increased. So this prothrombin time and APTT actually measures the clotting time, like how much time a patient is going to take to stop that bleeding. So that all depends on your clotting factor, that all depends on your platelets. But as this baby didn't receive this vitamin K, so this clotting factor 2, 7, 9, 10 will be deficient, and because of the deficiency of the clotting factor, the bleeding time will be normal. But of course, the body will take much more time to clot that, to stop that bleeding. And that is actually going to measure this prothrombin, and this APTT is the one which will give you a clue that these are the two factors which are responsible for a blood to stop bleeding. So these are called clotting time. They are making the clotting time.
Dr. Hira,
Yes.
please repeat kar dein.
See, there are two things. One is bleeding time and one is clotting time. In these patients who are having this hemorrhagic disease, of course, bleeding time will be normal. Why? Because bleeding time means that time to bleed. So that will be normal. But who is the one which is going to stop the bleeding? Clotting factors are the one which will activate the classical pathway and alternate pathway, and that will stop the bleeding. That thing is called clotting time, right? So clotting time in these patients actually increased. Why? Because these babies don't have vitamin K, and because of deficiency of vitamin K, there will be deficiency of the clotting factor. What kind of clotting factor? 4 clotting factors, 2, 7, 9, 10. And if these clotting factors are deficient, to think about, if there's a deficiency of clotting factor, the clotting time will be increased. Say, for example, I'm a normal one. I have all the clotting factors. If you cut my hand, it will stop bleeding in a few minutes. Whatever the normal person has to take time for stoppage of bleeding, that is called clotting time. So my clotting time will be normal. And in about 5 to 10 minutes, my bleeding will be stopped because I have normal amount of clotting factors in my body, and clotting factors are the one which will stop the bleeding. But think about the baby who is having hemorrhagic disease of the newborn. Once that baby is going to bleed, the baby is deficient in 4 clotting factors. Then what will happen? It will be a much more time as compared to a normal child to stop that bleeding. So we will see increased clotting time in those babies. And how you are seeing that, how you will say that the baby is having increased clotting time? When you look at the prothrombin time level and when you look at the APTT level. So if APTT is high, if prothrombin is high, think about the baby is having high clotting time. And why the baby is having high clotting time? Then think about maybe the baby is having some clotting factor deficiency. So if factor 8 or 9 is deficient, that disease is called hemophilia. And if 2, 7, 9, 10 is deficient, that disease is called hemorrhagic disease of the newborn. Are you getting me? So we have actually...
Dr. Hira, when bleeding time will be increased, the clotting time will be increased, huh?
Bleeding time will be normal in this patient because bleeding time means that, of course,
no, not in
time
this
is
patient, not in this patient.
Okay.
Whenever bleeding time is increased, the clotting time will be increased, huh?
You cannot say like that. Though both of them has no relation with them, because bleeding time is the amount of time that is going to bleed whenever the cut is there. So of course, if cut is there, the vessel is going to damage, it will start bleeding, right? So bleeding time means that the time to bleed, that is totally different phenomena. Clotting time means that the things in your body which are responsible to stop that bleeding. So how much time your body is going to take to stop that bleeding? That
okay, can you please interpret PT, APTT?
Yeah, so PT, APTT are the markers. Are the markers which will give you a clue. Say, for example, hemoglobin
I know,
is the marker. Hemoglobin.
But can you please explain them?
Think. Once the patient is having less hemoglobin, you say the patient is having anemia, right? Because of the less amount of hemoglobin. Same like here, the one who is having high PT and high APTT, you will say this patient is having high clotting time. Like why? Because prothrombin is the one who is going to be active. Prothrombin activator will be active. It converts prothrombin into thrombin. When thrombin activates, it converts fibrinogen into fibrin. When fibrin activates, it link with the platelets and help in blood clotting. So that's the whole phenomenon. It's not just one single thing. So it's not like that. What is actually PT is doing? Prothrombin time. Prothrombin time is the time in which you will see the prothrombin activator is going to be active and convert the prothrombin into thrombin. Once thrombin is formed, it will convert fibrinogen into fibrin. Once fibrin is formed, it will help the platelets to aggregate together and actually forming a clot. That we say it's a clot. So platelets are responsible in clotting of a blood, right? It will stop bleeding. So platelets are the one which will stop bleeding. So platelet will not going to work by themselves. There's a cascade of reaction by which platelet is going to active.
Okay.
So PT is the one.
This prothrombin time is that cascade to
yes, exactly.
To thrombin to fibrinogen.
Yes.
Okay. And what is APTT?
APTT, activated partial thromboplastin time. So activated partial thromboplastin time again is the one where we will see this thrombin is actually, thrombinogen is converted into thrombin. That's again in the middle of the whole cascade. So that's again is going to maintain the clotting time. So APTT or PT, both of them are responsible to maintain the clotting time. To maintain, not clotting time, just say to maintain the clotting. They are involved in the whole phenomena of clotting of blood. Right? And that's why we wholly depend. If these PT and APTT are raised, we will always think about that this patient is going to have an increased clotting time. There will be a lot of time in this patient to stop bleeding.
Please APTT repeat.
Yeah, APTT is activated partial thromboplastin time. Thromboplastin again is the one which is responsible to convert thrombinogen into thrombin. thrombinogen inactive form, thrombin is active form.
Okay.
And once the
It is-
thrombin
it
is
is-
formed,
It is even the initial step, then PT. It will occur before PT, the initial step before. to
PT
activate
is the
thrombin.
first one. PT is the first one because PT means prothrombin activator is going to activate and it converts prothrombin into thrombin.
So
Again, the value of thrombin is
APTT
going to be increased.
APTT is activating prothrombin, is even activating prothrombin.
Yes, both of them will go together. These both of will go together. They are like brothers and sisters. Once one is high, the other one has to be high because they are actually doing the same procedure. No? They are both of them are involving in the clotting mechanism. So you cannot say in the patient PT is increased and APTT is decreased. It cannot be like that. Once PT is increased, of course, APTT will also be increased.
So thromboplastin will be converted into.
Thromboplastin is the protein which is going to help to convert thrombinogen into thrombin. And then thrombin, once activated, it will help in again converting fibrinogen into fibrin. And once fibrin is there, it will help the platelet.
Thrombinogen into thrombin. Huh? Okay.
Yes.
Okay. Thank you very much.
So that's a whole physiology. If you are preparing for USMLE, you have to have this knowledge because they usually ask this pathophysiology questions related to clotting. Yeah. Now, which of the following is the most appropriate treatment? What you're going to give now is you have seen that this patient is a case of hemorrhagic disease of newborn. Why? Because he has born at home. So that will give you a clue, and he's having a bleeding, especially over this umbilical area. And you can see the clotting time is increased. Of course, 2, 7, 9, 10 are deficient because of the vitamin K deficiency. Which of the following is the appropriate treatment? Of course, you are going to give vitamin K. That's the only thing you can do. So we'll go for vitamin K. Now, the next question, a 5-day-old infant has significant nasal and rectal bleeding. Again, this boy is 5 days old. He was delivered by a midwife at home, again, home delivery. The pregnancy was normal and the baby had good Apgar score. He is breastfeeding well. It means that there is nothing there in the body, except that which of the following vitamin deficiency is the most likely the cause. So if the baby has nasal bleeding as rectal bleeding, so you can think about that this baby has born at home, so must be deficient in vitamin K. So the reason of this rectal bleeding and nasal bleeding, that is epistaxis, is just because of vitamin K deficiency. And you can give vitamin K at any time. Which of the following vitamin is administered to newborns to prevent hemorrhagic diseases? So of course, in LR, in labor room, as soon as the baby delivered, we have to give vitamin K. Okay, then for the next one, we have to go for the theory first. We go for hemophilia. Hemophilia, it's not very much in detail in MTB. So let me take you to Ambos first, and then I will take you to MTB as well. Okay. So hemophilia, of course, as we all know very well, it's an X-linked recessive. So it's a genetic disease, inherited or spontaneous mutation we will see in all these patients. Antibody production against clotting factors. So which clotting factors? Not all the clotting factors. If only factor 8 deficiency is there in the body, we will say it's hemophilia A. Whenever there is only factor 9 is deficient in the body, we will say it's hemophilia B. And when we say the factor 11 is deficient, we will say it's hemophilia C. So most of the time we have this hemophilia A and B, and among all these two, we usually find this factor 8 deficiency, that's hemophilia A. In 80% of cases, the patient must be having this hemophilia A, but again, 20% chance is there that factor 9 is deficient alone. We will say it's a hemophilia B, and it's very rare cases we will see it's factor 11 deficiency. So hemophilia usually affects male because it's an X-linked recessive, and male has only one X. So think about the one X, and if that X is carrying hemophilia, then of course the baby boy has becomes hemophilic and more ratio as compared to female, because female have two X's. So one is X is hemophilic, the other one is normal. The baby is going to be normal. Why? Because this disease is X-linked recessive disease. This is not going to be dominant if one gene is normal. So what are the clinical features? Clinical features are very important because early you detect these babies, the better is that, because we can easily protect those babies just by, most of the time we have seen this hemophilic patient, they are usually wearing a card or something, identities there which mention they are hemophilic, don't touch them, be vigilant with them, these children. So they usually have tags on their bodies because they are more prone towards bleeding. So spontaneous bleeding or delayed onset bleeding, of course, in these patients. So here I wanted to show you this one, which is not there in MTB. The hemarthrosis is the one feature which you will find a lot here. Even these children will, usually they fall on the ground, their joints started bleeding. That is like that. So very, very lethal bleeding we can see in these babies because they are lack in very important factors, deficiencies. So hemarthrosis is the one presentation which we usually see in hemophilia. So whoever the baby is presenting to you and the baby is having hemarthrosis, a part of this all purpura and gum bleeding and everything, if he is having hemarthrosis, think about hemophilia because that's a very severe thing. So recurrent, of course, bruising, hematoma formation will be there, epistaxis will be there, nosebleed will be there, gums bleeding will be there. So of course, every part will bleed a lot because there's deficiency of clotting factor. Once there are no clotting factors or less deficient clotting factors, of course, the bleeding will be too much because these clotting factors are the one who are going to stop bleeding or who will help in stopping the stoppage of the bleeding. So further symptoms of hemorrhage, you can see the hemorrhage can be inside the brain as well. It can cause neck stiffness, CNS can be involved. We can see in the GI, they will present, these patients will present like melena and hematemesis, genitourinary hematuria. So every organ is going to be involved because bleeding is there, and the presentation will be like that. Like in case of renal system, hematuria; in case of GI, you will see melena. Upper GI bleed, you will see hematemesis. Lungs are bleeding, you will see hemoptysis. So of course, mild hemophilia means hematomas forming severe trauma, following severe trauma. If there is trauma and because of trauma, the blood clots are there in the body, you can say it's a mild hemophilia. And most of the time it's factors 8 or 9 are deficient. Moderate hemophilia, hematomas following mild trauma. And severe hemophilia, even though if the child fall, then it will become, severe spontaneous hematomas, just after falling. If a normal child fall, nothing will happen. But if these hemophilic child fall, then what will happen? If they are having severe hemophilia, you can easily appreciate too much hematomas on the body just by falling, or even if you just hold them tightly, again they can start bleeding. The things inside the soft tissue structures can bleed. So they are very fragile. So in case of severe hemophilia, now pedicle bleeding is common sign of platelet disorder. Of course, whenever you see any kind of a skin beneath the skin, if there is bleeding, which is actually called as pedicle rashes or purpuric rashes, that's a clear clue that this is all because of platelet disorder, but not of coagulation disorder such as hemophilia. So these patients, you will appreciate clearly bleeding inside this one, not only just beneath the skin. Whenever there is bleeding in beneath the skin and that gives a purplish appearance, that most likely give you a clue that it's a platelet deficiency. It's not a clotting factor deficiency. But whenever there is too much bleeding, obvious bleeding is there, you can find the red blood is coming out from the structure, then you can say it's not a platelet bleeding, it's a clotting factor deficiency bleeding. But once you see the bleeding is there and now it's converted into purplish thing and purplish stria are visible just beneath the skin, that most likely because of most likely because of platelet deficiency, not this clotting factor. Clotting factor are the one which are responsible for the platelets to clog up and aggregate and form a clot. So how we are going to diagnose these children? Of course, patient and family see genetic. It's a genetic one. Right from the beginning, we can screen for all the testing. You can go for this PT, APTT, and everything. Of course, clotting will be prolonged, so you can see APTT will be prolonged here. But as such, there are no platelet dysfunctioning here, so you may find prothrombin time exactly normal in these patients. If APTT prolonged, we will go for the mixing study. Mixing study means that we will just take the blood of a normal patient and we will check whether these patient how much time will be there in order to stop the bleeding. So that is called mixing study. We will mix the normal blood with the patient's blood just in order to see if there is any improvement or not. So of course, in the normal blood there are clotting factors. In the abnormal blood or in this patient blood, the clotting factors are deficient. So you will find that the clotting factors are there and they will of course help in stopping the bleeding. Okay. So for the treatment option, what you're going to go for these patients, of course, whatever the clotting factor is deficient, just give that clotting factor. So if factor 8 is deficient, you will give a factor 8. If 9 is deficient, you will give factor 9. If factor 11 is deficient clotting factor, then give 11. And desmopressin. Desmopressin is DDAVP. We will usually give, it's one of a kind of vasopressin, and we will give desmopressin, especially in case of hemophilia A patient. What it's going to do? What is the normal mechanism of action of this desmopressin? It triggers the release of one Willebrand factor from the endothelial cell, which lead to increase in factor 8 plasma concentration. So this von Willebrand factor is, again, it's another factor that is going to convert into factor 8. So if factor 8 is directly not there in the patient's blood, but von Willebrand, of course, is there. So this desmopressin, when you give from outside, this desmopressin will help in converting the one Willebrand factor into factor 8. So you will see that the sort of factor 8 deficiency will be getting over. Like you can get over the deficiency of factor 8 just by converting this one Willebrand factor into factor 8. And who is going to convert that? That desmopressin is going to convert that. So these patients will get benefit when you just give this desmopressin. Or other than that, you can directly give vitamin K, this factor 8 from outside. So two options: you can directly give factor 8, or you can give desmopressin. Desmopressin is going to convert von Willebrand into factor 8. Now this emicizumab description, a humanized monoclonal biospecific antibody that reduces the risk of bleeding event. So if any kind of this kind of medicine you are giving, so they are actually going to reduce the risk of bleeding. So you can say it will help in the progression of the disease, but of course the disease which is occurring in the body, it's not going to help in that one. Only the chances of recurrence or progression of the disease, that is going to be cured, that is going to be covered if you are using this emicizumab. So of course in hemophilia A, we will going to give this to our patient. So think about only if hemophilia A is there, so you have to give factor 8. Else you will give in combination desmopressin, that will convert the von Willebrand into factor 8. And last resort you have, just in order to progress the disease, we can give this emicizumab. That's one of an antibody you are giving from outside, that is going to reduce the risk of antigen antibody reaction. So let's have a look at the questions. Here is saying, which of the following signs are more likely to be associated with hemophilia? More likely to be associated with hemophilia. Just after seeing that sign, you have to make a diagnosis. Okay, the baby must be having hemophilia. Epistaxis, nosebleed. Do you think just after seeing the nosebleed, you can say the patient is hemophilic? Of course not, because epistaxis is just a nosebleed. Maybe sometimes the children are poking their nose, a lot. So what happened? They are actually damaging the superficial vessels of the nose, so that can also bleed. Sometimes the baby is feeling too much hot. There is too much too much temperature around the surrounding. Then what will happen? There will be, the nose is working as an air conditioner, and because of the working as an air conditioner, there will be vasoconstriction, and the child or any person can bleed. You cannot say epistaxis is only a sign of hemophilia. There are so many conditions in which there's just a regulation, because nose is actually performing the air conditioning of our body. So at that time, we will also find epistaxis. So epistaxis is not the one based on which you can say the patient is having hemophilia. Gum bleeding, again, gum bleeding can be there in henoxian line purpura. Gum bleeding can be there in ITP, can be there in PTP. Any kind of platelet disorder can present with gum bleeding. You cannot say by seeing just gum bleeding that it's a case of hemophilia. Of course, in hemophilic patient also they have gum bleeding, but that's not the very much symptom you can appreciate. But hemarthrosis, you remember, I've emphasized a lot on this hemarthrosis, because hemarthrosis is the one which is actually showing the severity of the bleeding. And this severity of the bleeding is only because of the deficiency of the clotting factor. And which clotting factor? Most likely 8 and 9. So that's why hemophilic patients, they usually present with hemarthrosis. So if hemarthrosis is there, you have to have, make a diagnosis of hemophilia. Petechial hemorrhages, we have already covered this one. Petechial hemorrhages are because of the platelet deficiency. So think about thrombocytopenias, not hemophilias. So answer should be hemarthrosis. Hemarthrosis, like joints are bleeding, that is the worst thing you can see in hemophilic patient. Okay, for this one, you have to go for the theory first. Nephrotic syndrome. Okay, For the nephrotic syndrome, as the name indicates, nephrotic, nephritis, kidney is a measure of the severity of proteinuria and association with any form of glomerular disease. So maybe in this patient, the patient must be having glomerular disease. But of course, we know very well glomerulus is the one, the basement membrane of the glomerulus, which when damaged, then what will happen? It can pass, protein from inside the body to outside. Usually the proteins are not actually filtering from the glomerulus because of the glomerulus membrane, basement membrane, endothelial membrane. But once the damage is there because of any reason, these proteins which are normally not filtering out into the urine, but because of the damage to the basement membrane, they will filter out and they will go into the urine, and the patient can present with proteinuria. So here we will say it's a measure of severity of proteinuria. There will be too much proteinuria, proteins are lost in the body in association with any form of glomerular disease, any kind of glomerular disease. Maybe the post-infectious glomerulonephritis is there. Maybe any kind of polyarthritis, any kind of Goodpasture syndrome, vasculitis is there. Maybe lupus nephritis is there. There are so many types of glomerulonephritis. Any kind of glomerulonephritis is there. But if in that glomerulonephritis there is too much proteinuria, the proteins are lost too much because of the damage to the basement membrane, nephrotic syndrome occurs when proteinuria is so massive that the liver can no longer increase the production of albumin to compensate for urinary losses. Then what will happen? The usual body mechanism is that once we lose protein, right? Maybe because of any reason, maybe because of glomerular damage, I am losing my protein. Then what will happen? If I'm a normal person, my liver has to work. My liver, what is going to work? My liver has to work in such a way that it has to produce more albumin, and then albumin will, because albumin is a protein, that albumin is going to compensate the duty of that protein which is actually lost in the urine. That's a normal body physiology. Once we are losing proteins in the urine, the liver has to work a lot. Liver has to produce albumin in order to compensate the protein which we have already lost in the urine. Why the liver is working all this? Because liver knows very well protein is the main buffer mechanism of our body. Is the one who is going to maintain the pH, is the one who is going to carry all the all kind of structures properly in their places. The protein is the one who is actually maintaining this extracellular, intracellular compartment, fluid compartment. So once you know the functions of protein, you can imagine what kind of protein is, what functions protein is doing in our body. So if that protein is lost in the urine, there has to someone who has to compensate the loss, and that's the liver. But in case of nephrotic syndrome, think about this one, that protein is losing, the body is losing protein too much because of the glomerular damage, but liver cannot be capable enough to compensate that loss by forming the albumin. There comes the definition of nephrotic syndrome. Whenever there is a disturbance, whenever the whole equilibrium of the body is disturbed, the body is losing protein a lot, but liver is not actually capable enough to make albumin in such an amount or in that amount which can compensate the lost amount. There comes the term nephrotic syndrome. So here we will see there will be the liver can no longer increase the production of albumin to compensate for urinary losses. Then massive proteinuria leads to, now what will happen? There will be too much edema. Or the protein is not there in the body. The protein is the one who is going to maintain the oncotic pressure, the one who is going to capture the fluid, the one who is going to maintain the whole intracellular, extracellular compartment fluids in hands. But once the protein is not there, the whole fluid is going to come into the extracellular spaces. There will be no intracellular fluid. Then what will happen? There will be too much edema. The whole body is getting edematous. There will be hyperlipidemia. There will be thrombosis from urinary loss of the natural anticoagulant. Not only, what kind of protein is losing in the urine, that also depends. If clotting proteins are removing, say for example, protein C, protein S, and antithrombin proteins, they are actually going from outside the body, then what will happen? There will be thrombosis too much. So think about every protein who is going to loss from the body, and what is the function of that protein. You can think that that mechanism will be disturbed. So if the clotting proteins are going to be excreted in the urine, then the whole thrombosis will be affected. Whole clotting mechanism will be affected, and there will be thrombosis in the patient. If a protein who is actually maintaining the oncotic pressure, actually maintaining the intracellular and extracellular fluid compartment levels, distributing the plasma into and outside of the tissue, then what will happen? There will be too much edema because protein is not there. Protein is the one who is actually capturing the fluid and maintaining the oncotic pressure. If there is no protein, then what will happen? There will be too much edema. So think about this one. What are the functions of the protein? And those functions are actually not going well. Why? Because protein is deficient.
Excuse me, Dr. Hira, what is thrombosis?
Thrombosis means you will see because of the deficiency of protein C and protein S, there will be less clotting. There will be no clotting. Once the bleeding is there, the internal bleeding will be a lot. And thrombosis is the term where we will see that this thrombin has to activate the whole phenomena. There should be some blood clotting. So once the liver is not working, bone marrow has to work a lot. And then we will see there will be a compensating mechanism just in order to stop that bleeding. There will be too much internal clotting inside. That thing is called thrombosis. Like once there is no protein C, protein S, there will be, the whole clotting thing is disturbed. The bone marrow has to function, the spleen has to function in order to compensate that thing, because we know very well this bone marrow and spleen, there are body defenders, right? When it comes to liver pathology, they will become active. This is spleen and this bone marrow, and they will produce more thrombin, and you will see more phenomena of blood clotting inside the normal vessels. Also blood is going to start clotting, and that thing is called thrombosis. So that is the natural compensation against this liver thing, that liver is no more capable to produce more amount of protein C and protein S, and normal clotting is not there. So in order to compensate, the spleen and bone marrow will work, and they will produce a lot. So as a result, when there is a lot of thing in there, then you will see more and more clotting inside normal vessels. Inside the normal tissue, you will start seeing the clotting is there. So that thing is called thrombosis. Excessive thrombus formation, excessive clot formation. And think about the results of that one. If there are too much emboli, too much clots, it can go into the brain, can cause brain hemorrhage. It can go into the heart, can cause myocardial infarction, can go anywhere and cause infarction. Think in that way. So you can appreciate the swelling is there, too much extracellular swelling. Now, overall, diabetes and hypertension are the most common causes of nephrotic syndrome. Now, they are giving you a clue that in most of the time, those who are diabetic and those who are hypertensive, in these patients, we usually say they are more prone towards having this glomerular diseases, and they can be having this nephrotic syndrome at any age of life. Any of the glomerular disease just described may lead to such massive protein loss that nephrotic syndrome develops. So not only this glomerular diseases, they have association with diabetes and hypertension also, that there are also other etiologies, a part of this glomerular diseases, which can result in nephrotic syndrome. But the thing is that you have to have in your mind that too much protein will be lost in the urine, and liver is not going to compensate that thing. That's why we will see massive nephrotic syndrome in the body. So the major difference between nephritic and nephrotic is the amount of proteinuria. When the word says massive protein loss, think about nephrotic syndrome. In nephritis, we will not see that much amount of proteinuria. Nephritic is just like inflammation of the nephrons, nephritis. Now, in addition to systemic diseases, there are a number of diseases limited to the kidney that produce nephrotic syndrome. It is better to describe association rather than causes, since we don't know what causes nephrotic syndrome, but it is quite obvious that those who are having glomerular diseases and those who are diabetes and hypertensive, there's a strong relation of those person with nephrotic syndrome. But some type of cancers are there which has relation to this nephrotic syndrome. In some children those who are having this minimal change disease, vasculitis diseases, they are also prone towards getting this nephrotic syndrome. Some infectious agent injecting drugs, or like the one who's having immunodeficiency, AIDS, HIV, these are the things which can cause focal segmental damage of the glomerulus membrane, and that can also cause nephrotic syndrome. So there are all the associations you can think in which kind of thing the patient can get nephrotic syndrome. If the patient is using too much amount of NSAIDs, that's the very most important thing. See, we have to counsel our patients generally also. It's our duty to counsel them, don't go for home medication. Since they're having only, this headache, they used to take this Panadol a lot. They don't know actually by taking this simple Panadol too much, or by taking NSAIDs, what they're actually doing. They are causing nephrotic. They are actually getting this thing that their kidney can, their renal function compromised, and they can present with nephrotic syndrome later in life. So that's very important thing. We have to counsel patient, please don't go for self medication. Like it's not like that if you have pain anywhere in the body you have to take NSAIDs. No, there should be a proper treatment. You should treat the cause of the disease rather than treating the symptom. But it's okay, sometimes we may need to treat the symptoms as well, but that's the important thing, that we should know the cause of the disease and we should cure the cause rather than the symptoms. So NSAIDs is the one that later in the life can cause this nephrotic syndrome. How? Because this NSAID can cause minimal change disease in the glomerulus and can cause membranous glomerular nephropathy, and the patient may present with nephrotic syndrome later in life. SLE, lupus nephritis, one of the glomerular disease, can present with nephrotic syndrome. So what will be the presentation? In these patients, nephrotic syndrome present with generalized edema. We have seen this one. Infections are more frequent. Of course, the whole immunity of the body is going down because of increased urinary loss of immunoglobulins. Which kind of protein is actually losing in the urine? So if immunoglobulins are losing, think about the whole immune system is going to be lost. But the patient is now will become opportunistic. There will be too much antigen antibody reaction in the patient because the body defender proteins are actually not there in the body. Clots are more common from loss of antithrombin protein C. So if clotting factors dependent proteins are actually losing from the urine, then the whole clotting mechanism will be disturbed inside the body. Now, congestive heart failure leads to edema of dependent areas like the legs. So that's the important thing, because most of the time this congestive heart failure also present with the edema, but that should be the dependent areas of the legs. But in case of nephrotic syndrome, you will see edema everywhere, because the protein is the one which is actually there in the whole body. The protein is the one who is going to maintain the intracellular and extracellular oncotic pressures. So think about whenever there is an edema because of nephrotic syndrome, that is all over the body. But if it's only restricted to the leg areas, then we can say, okay, it may be the reason of congestive heart failure, not because of nephrotic syndrome. But nephrotic syndrome presentation edema will be all over the body. So what you are going to do to see? First of all, we need to look at the proteins. So we'll go for urinalysis. We will see whether the person is actually losing protein in the urine or not. So the best initial test will be urinalysis. We will go and check for the complete urine detailed report. You want to see how much amount of RBCs the patient is losing urine, how much WBCs, how much cast cells, how much protein, everything, and that will only give you when you go for the whole urinalysis. Protein levels on urinalysis roughly correspond to the amount of protein excreted over 24 hours. So, however, since renal function varies with the time of day as well as posture, like those who are flat or those who are upright, if we are upright, the body has to work a lot because anti-gravity. So, of course, at that time, we will see different amount of proteins level. So, the urinalysis is not sufficiently accurate. That's why we have to have some more. It's okay, the initial one is urinalysis, but we have to have some other tests also in order to make a definitive diagnosis. So you can have trace protein urea on urinalysis and 2+ protein on another, but urinalysis only detect albumin as a protein. So this is again very important on urinalysis. When we say protein plus plus, we are actually referring to albumin. Like albumin is actually losing in the body, losing in the urine, and that's why we say if it's mentioned protein plus plus in urinalysis, actually the urinalysis is only able to detect albumin in the urine. So it's only referred to the albumin, not the other proteins. So the urine albumin creatinine ratio gives a measure of the average protein produced over 24 hours. A ratio of 2:1 means 2 grams of protein excreted over 24 hours. A ratio of 5.4 to 1 means 5.4 gram excreted over 24 hours. So whatever the result is there, just think about that. If 2 is there, 1 plus 1 is there, plus 2 plus 3, it actually corresponding to the grams. Like 1 plus 1 means 1 gram, plus 2 means 2 grams, plus 3 means 3 grams. So this we will see. Periorbital edema is a characteristic of nephrotic syndrome. Of course, periorbital, not only periorbital, the whole edema anywhere in the body. So think about the anti-gravity, periorbital, not only leg dependent or gravity dependent, which is happening in the congestive heart failure. So that's a very important clue. Once the baby or any person, any patient presents to you and having periorbital edema, the puffiness around the eyes, you can think about nephrotic syndrome. The urine albumin to creatinine spot urine ratio is equal to a 24-hour urine in terms of accuracy and is much easier to obtain. So the first thing, you will always go for urinalysis. The second thing which you are going to measure in your patient is urine albumin to creatinine ratio. That should also be high, urine and creatinine. So creatinine, if the creatinine is high in the urine, that will also give you a clue that kidneys are not working, because creatinine should be regulated if the kidneys are functioning fine. If creatinine is excreted too much in the urine, think about that your kidney is not working. That's why the creatinine levels are high. And of course, if albumin also high, think about there is too much massive glomerular damage inside the kidneys. So pathology is like the functioning is also disturbed and the morphology is also disturbed, because the basement membrane is damaged. That makes the morphology of the kidney. So here, not only the functioning of the kidney is lost, like creatinine is excreting too much, that's the functioning of the kidney. Not only the functioning is disturbed, but the whole morphology of the kidney is disturbed. So both of the things together. The urinalysis show Maltese crosses, which are lipid deposit in slough of tubular cells. So in urinalysis, you can also see that lipids are also, not only proteins. Now, lipids are also excreting out in the form of these Maltese. So Maltese is the one which are actually the lipid deposits in slough of tubular cells of kidney. So once the tubular cells of kidney are damaged, they can release this Maltese, and these Maltese are just like lipid droplets. Tissue lipid deposits. So you can say not only protein, but lipids also started to excrete out. So what we will do renal biopsy. Renal biopsy is the most accurate test of the cause of nephrotic syndrome. Although there are certain association with each form of nephrotic syndrome, only the biopsy can distinguish. So only on the basis of biopsy, you will see what exactly the histopathology problem is there. Where exactly the glomerular membrane is damaged. Who is actually responsible? Either it's a crescent formation who is responsible, either it's an antigen antibody complex who is responsible for the glomerular damage. And that's why you can easily say, okay, this is the particular disease who is responsible for this whole damage. So you will think about, okay, the focal segmental damage is there, the membranes are involved, membranoproliferative is there, minimal change is there, mesangial is there. So these are all the things based on the histology. So what kind of thing is involved, that will produce. So if mesangial cells are the epithelial cells, if they are involved, we can say it's a mesangial nephrotic syndrome. If there is minimal change disease, only vasculitis is there, because of the infection, we can say minimal change. Membranoproliferative inflammation is there. Membranous, again, the basement membrane is damaged. Focal segmental, any one particular part of the kidney, if it's showing damage, that is focal segmental. So it depends. You will only differentiate on the basis of renal biopsy. Now, by definition, nephrotic syndrome is you will see too much amount of protein in urine. That is called hyperproteinuria. How much? We have set one deadline. It should be more than 3.5 grams per day. Then you can say, okay, it's a massive proteinuria, and this massive proteinuria means it's a clear case of nephrotic syndrome. Plus, of course, inside the blood, there will be too less protein because liver is not capable enough to compensate the loss. We will see hypoproteinemia. Inside the blood, the protein will be less. Hyperlipidemia, lipid will be increased. Lipid will be increased in the blood, and sometimes lipid will also be excreted. But that's only when the tubular damage is there. If tubular damage is not there, you will not see Maltese, these lipid deposits going out from the body. Edema, because
Dr.
of
Hira,
less protein.
how
Yes,
hyperlipidemia will develop?
Hyperlipidemia, because see, this lipid and protein metabolism, that's the whole thing which are actually responsible for maintaining the buffer mechanism. So once proteins are not there, then lipid has to work in order to maintain the oncotic pressure. That's a defense mechanism. So if protein is deficient, then the other thing is lipid is going to work as a buffer. So you will see more and more amount of fatty acid just in order to compensate the loss of protein. Then lipid deposits, fatty acids, and glycerols, they are responsible to maintain the oncotic pressure. That's our body defender. Same like when one thing is not there, the other thing has to function. Say, for example, sodium and potassium. You know, to think about that one, their function. If both of them are ions that has to work along. So if one is not there, the other has to work along. So same in this way. If proteins are less, the lipid has to maintain the oncotic pressure. Yeah.
No, this means that lipids will be more in the extracellular
Not in extracellular.
fluid
Yes,
to maintain
yes, plasma.
maintain this
Plasma.
body.
Yes, you can say.
But
Extracellular means plasma is also
there will
part
be
of
relative.
extracellular.
There will be relative hyperlipidemia, not a real. Huh?
Yeah, of course. And that hyperlipidemia always secondary to protein, less proteinuria. When you see when you see first the proteins are getting high, then the second you will see this hyperlipidemia. Hyperlipidemia itself is not a basic or first presentation. It will be always a second and third presentation. Later on, when it's too much damage is there, then only lipids started working. Of course, it will take some time to see the high lipid levels. It will not be like that, like on the day when you diagnose nephrotic syndrome, you will find hyperlipidemia. Maybe in weeks or in days, you will find hyperlipidemia. Yes. And
Okay.
hyperlipidemia can be alone as well, and there is no association with the proteins. So lipid level rise, now they have mentioned pathophysiology, because the lipoprotein signals that turn of the production of circulating lipid are now lost in the urine. So again, you will see, because maintaining of the lipid level is also dependent on the protein. And which protein is that? That's the lipoprotein. Lipoprotein is the one which is going to maintain the whole metabolism of lipid. So what is happening if there is too much loss of the protein? Maybe we will see this less amount of lipoprotein as well. So because of the lipoprotein signaling, that turn off the production of circulating lipids are now lost in the urine. With loss of these lipoproteins, that's around chylomicrons and very low density lipoproteins, all lipid levels in the blood will rise, because we see very well this very low density lipoproteins and high density lipoproteins. They are the ones which are formed from the lipid and proteins together. So think about, it's not only the protein who is responsible. The things are lipoproteins. They are the actually proteins which are actually maintaining the whole metabolism of lipids. They are interdependent each other. So that's why we will see high levels of lipids. And iron, copper, zinc are low because their carrier proteins is lost in the urine. So why iron, copper, zinc are low? Because they need some protein to travel. So once the traveler protein is not there, which is called carrier protein, think about this copper and zinc iron will also not work properly. Why they are not working properly? Because their carrier protein is actually lost in the urine. So it's not only albumin, it's not only about albumin, it's about protein. So protein is involved everywhere in making the carrier proteins, in making the lipoproteins, and making, maintaining the lipid metabolism, in maintaining the oncotic pressure. Everywhere proteins are involved. Anyhow, protein is a building block unit of our body. Right? So think about that. Now, anything with a carrier protein can be lost in the urine. Now, treatment. So what you're going to give to your patient who are going to present with this massive proteinuria, we will give them glucocorticoids. If there is no response after several weeks of therapy, then we can also go for other immunosuppressive medication. So first we will give glucocorticoid. Glucocorticoid, what they will do? They will do the anti-inflammatory action. They will help the glomerulus to heal. But of course, whatever the damage is there. It cannot be reversed. And we can give immunosuppressive that can decrease the progression of the disease. Now, ACE inhibitors or ARBs, of course, you can try. I used to try control proteinuria. So if there too much proteins are losing in the urine, maybe we can try this angiotensin receptor blocker, and they can just hold the protein inside. Edema is managed with salt restrictions and diuretic. So if you just ask the patient to restrict the salt intake, dietary intake, and use of diuretics, so that lots of amounts of extracellular fluid can be removed, but that's not the curable thing, right? That's only the symptomatic relief. This edema is again going to be there. It's no matter how long the diuretic the patient is going to take, then the patient has to take diuretic for a longer period of time. It's just a symptomatic relief. Hyperlipidemia is managed with statins. So you can start the statins just in order to prevent hyperlipidemia, as you would form any form of hyperlipidemia. So like the one which you remember, if you have done this coronary artery diseases, you must have done this one. That statins we have to start it just in order to prevent hyperlipidemia, especially in diabetes, when this LDL level should be in between 70 to 100. Our main aim is to maintain the LDL, because LDL is the one who is going to maintain all the lipid metabolism. So we can start statin in these patients, those who are presenting with hyperlipidemia. So but remember, the best initial therapy in nephrotic syndrome will be glucocorticoid. For stopping the progression of the disease, cyclophosphamide. For preventing the proteinuria, ACE inhibitor. For preventing the hyperlipidemia, statins. For maintaining the edema and all that, salt restriction and diuretics. Again, the whole symptomatic relief. So look at the questions. Okay, this one. The 2-year-old boy presented to the outpatient clinic with a 2-week history of facial swelling. Now, facial swelling, periorbital swelling, poor dietary intake, reduced activity with a positive sacral edema. So edema is not there on the face, but on the dependent areas also. You can say the whole body is now involving. Blood pressure is decreased, heart rate is it's okay, respiratory rate is okay, and temperature is okay. Test results show hemoglobin, low hemoglobin, 94. Alanine aminotransferase, you can see the LFTs, the liver enzymes, they are increased, 52. Albumin is the main who will give you a clue why the baby is presenting with swelling, why the baby is presenting with edema. So albumin is clearly very low, it's 25. So whenever albumin count is low, whenever there is hypoproteinemia, always think about there is something wrong in the kidney. Now total cholesterol is high. So hyperlipidemia associated with hypoproteinemia, associated with dysfunctioning in the body, like LFTs are deranged. Here you can see the low hemoglobin count, and there you will see 2-week history of facial swelling, not only on the upper part periorbital, but on the dependent areas as well. It means that the whole body involvement is there. So what do you think? Which of the following is the most likely diagnosis? Do you think it's a congestive heart failure? In order to make a diagnosis of congestive heart failure, there should not be any facial swelling, because congestive heart failure always present with dependent area swelling, like leg swelling, bilateral leg swelling. Chronic liver disease, just only because of alanine aminotransferase increased level, you cannot say it's a case of CLD. In order to make a diagnosis of CLD, there has to some liver function, the whole derangement of the liver function. There's not only ALT, AST, SGPT. You will see increased amount of all the liver enzymes, not only alanine aminotransferase, especially who is the one whose main precursor is protein dependent. Nephrotic syndrome or protein malnutrition. If the baby is protein malnourished, okay, the baby can present with the swelling and all that. But what about the other things? Why the hemoglobin count is low? Why the LFTs are deranged? Why the baby is having this one? Okay, facial swelling can be there in protein malnutrition, but again, it depends what kind of protein malnutrition is there. Either it's a Horschifer or it's a marasmus. If it's a marasmus, the baby is presenting just like a zombie, the whole flattened body, the whole shrunken body in marasmus. That's a protein deficient body. And the other one, it's the whole bulky body, where you can see the whole just like an apple plum, basically the too much watery content inside the body. That's a Hashimoto's disease. So that depends what kind of protein malnutrition is this. You cannot say just protein malnutrition, because protein malnutrition can present with two things. Once the whole protein is damaged, or once because protein is not there, and because protein is not there, no one is going to hold water and the whole body is become edematous. So it depends what kind of thing. But here the presentation is not like that. Marasmus is also not there. Hashimoto's presentation is also not there. So we cannot say it's a protein malnutrition. It's a clear case of nephrotic syndrome based on the presentation of periorbital edema, based on the presentation of sacral edema, based on the thing that albumin is low. One of the most important thing here in order to make a diagnosis is albumin. So hypoalbuminemia, like protein is less in the blood, plus you can see this hyperlipidemia. These are the two things in combination with edema, dependent and non-dependent. That will give you a clue of nephrotic syndrome. Okay, for the next question. A 7-year-old child presents to the medical outpatient with a parent who reports edema over the face, again periorbital edema, facial edema. Examination of urine shows selective proteinuria, 3.5 gram per day. So just proteinuria who's showing 3.5, it's itself alone proteinuria, massive proteinuria alone is diagnostic of nephrotic syndrome, making a diagnosis of nephrotic syndrome. If it's less than 3.5, then we may think about something else. We may think about any glomerular infection. But if it's clearly mentioned that proteinuria is 3.5 or more than 3.5, always think about nephrotic syndrome, because this is massive proteinuria. Now, which of the following is the most likely diagnosis? Two things are very important here: periorbital edema plus massive proteinuria. That will help in making a diagnosis of nephrotic syndrome. Nephritic syndrome is very less proteinuria, maybe +1 or +2. You will never find 3.54 here. Of course, it's a nephrotic syndrome. Okay, for the next one, we have to go for the theory first. Then we have this hemolytic uremic syndrome. Okay, 618. Okay, so for hemolytic uremic syndrome, there are the two variants actually, and both of these go together. One is TTP, thrombotic thrombocytopenic purpura, and the other term is hemolytic uremic syndrome. What is happening here? In both of these things, we will see there are certain associations, and especially the association of what is happening here. There will be too much intravascular hemolysis. The blood is actually going to lyse. There will be hemolysis, the renal function is going to be compromised, and there will be platelet count deficiency. You will see the platelet less than 30,000. So if there is any association of organism, and especially two organisms, after the infection of two organisms, one is E. coli and one is Shigella. These two, especially these two organisms, once the infection is there, because of these two organisms, and then you will see that the patient has developed intravascular hemolysis. There is hemolysis, the blood is going to lyse everywhere, the renal system is compromised, and the platelet counts are low. So that's a triad of three things. After the infection of E. coli, after the infection of Shigella, if there is hemolysis, if there is renal insufficiency, if there is platelet count, decreased platelet count less than 30,000, always think about hemolytic uremic syndrome or TTP. Now, the hemolysis is visible on smear with schistocytes. Of course, whenever we say hemolysis, so hemolysis, how you're going to see on the picture, on microscopic picture, you will see schistocytes. So that's the thing which will give you a clue. Okay, there is lysis of blood. Helmet cells, these are the fragmented cells of the blood cells, and fragmented red blood cells. So these three cells are suggestive. Whenever you find these three cells in presentation in microscopic slide examination, if helmet cells are there, fragmented red cells are there, schistocytes are there, it will give you a clue that hemolysis is occurring. Moderate hemolysis is there. That's why all the cells are there. Now, TTP is associated. Whenever we say specifically TTP, there should be some neurological symptoms. Neurological symptom, why? It's a thrombotic thrombocytopenic purpura. So here we will see purpuras are actually there because of thrombocytopenia, and thrombocytopenia means that decreased blood count. So decreased platelet count. So because of the decreased platelet count, because of the deficiency of the platelet, purpuras are there. So we will see, and because of this one, we may find this neurological symptoms. What kind of neurological symptoms we can see? Most of the time, we will see clots in the brain. So, and if clots are there in the brain, then what will happen? There will be the focal damage to that area. And sometimes they can present with fever also. So TTP does not have to have all 5 manifestations to establish a diagnosis. In fact, the only dispensable finding to establish is intravascular hemolysis. So for TTP, of course, Shigella infection, E. coli infection, they are there. That's why the patient must be having this infectious symptoms because of the infection. Apart of that, if you see only intravascular hemolysis, everywhere, if you see the blood is lysed and you are going to experience, the patient is going to experience purpura everywhere, we can say it's a TTP. A low ADMTS 30 level supports the diagnosis of TTP. Now, once you do this complement level protein testing, you will see if it's positive one, that will help you, that will make you help, in making a diagnosis of this TTP. In TTP, you will always see low level complement proteins. So PT and APTT are normal in us. There is no relation with the clotting. Only platelets are the one, not the clotting factors. You remember, we have already discussed this one, that whenever there is a deficiency of the clotting factor, you will see abnormal prothrombin time and abnormal APTT time. But whenever there is a deficiency or something wrong with the platelets, you will not find anything related to this PT and APTT. Of course, when platelets are there, you will see like bleeding will be increased. You will see platelets, because platelets are the one who is going to form clot, and because bleeding is too much there, you will see purpuras and everything like bleeding inside the skin. Everywhere you will find bleeding accumulated inside the tissues. So PT APTT, of course, will be normal here because there is no wrong with the clotting factors. It's only about the platelets here. Thrombocytopenia, decreased amount of platelets, not the clotting factors. So these are the schistocytes, helminths, and fragmented cells. You can easily appreciate on microscopic examination, and that will give you a clue that this is a hemolysis. So whenever you do the examination, microscopic examination, and you find this schistocytes or fragmented cells or helmet cells, they will give you a clue that this patient is undergoing hemolysis. So most cases of hemolytic uremic syndrome from E. coli will resolve spontaneously because it's an infection. Once the infection goes, it will be reversed. Plasmapheresis is generally urgent in TTP. You have to remove all these unwanted cells, all these fragmented cells. You want to remove these cells from the blood, and the procedure is called plasmapheresis, where you are going to remove these unwanted cells. And if plasmapheresis is not one of the choices, then go for infusion of fresh frozen plasma. What we are going to get in fresh frozen plasma? In fresh frozen plasma, we will get too much amount of platelets. So that's how, or not only platelet, this plasma is also having fibrinogen, a lot amount of fibrinogen. So fibrinogen can be converted into fibrin, and fibrin, what will do? Fibrin will help in coagulation of blood. Fibrin will help platelets to coagulate together and to form a clot. Whatever the platelets are there in the body, but they will function very good in the presence of fibrinogen, because fibrinogen is the one who is going to be converted into fibrin, and fibrin is the one who is going to help in coagulation of this and clogging up of this platelet and forming a clot. Help in clotting the blood. This eculizumab treats severe atypical HUS, and atypical means HUS does not arise from the infection. So if because of the infection is there, this hemolytic uremic syndrome, we can use this eculizumab, this antibodies we can use. And atypical means does not arise from infection. Instead, it occurs when complement erroneously attack red blood cell. So once complement proteins are going to damage our own cells, that's a separate thing. We call this as atypical. And what do we mean by and if complement proteins are involved, then again we can use anti-antibodies. So eculizumab is the one who is going to act on this complement protein, who is responsible for damaging these platelets. So eculizumab blocks complement C5a, and this is why vaccination for meningococcus is required with eculizumab use. Why we are asking for this vaccination? Because we know very well meningococcus is the one which can cause blood poisoning. Blood poisoning in the sense, why we are saying it's a blood poisoner, because it can, once the bleeding is there will be too much massive bleeding because of this meningococcal infection. So we have to give some vaccination. We have to give some prior once we start these antibodies, because once these antibodies medication is going to start, they will work on complement system, and once the complement system is disturbed, there will be too much bleeding, because these complement pathways are the one which will help in clotting of the blood. This complement pathway, classical pathway and alternate pathway, these complement proteins are responsible in clotting the blood. So if you are using something against this complement protein, you have to make sure that other things should not go wrong. So that's why they're saying we have to give always meningococcal cover when we are giving any kind of antibodies from outside. Why? Because they are going to work on complement system, and complement system is the one who is responsible for preventing the who is responsible to maintaining the whole bleeding and clotting. Complement pathways, complement proteins are responsible for maintaining the complement pathway. Remember, complement pathway and alternate pathway, they are the pathways of formation of clot. So steroids help in TTP, but not in HUS. So steroids, anti-inflammatory, they can help in releasing, they can help in TTP, but not in HUS, because mainly in hemolytic uremic syndrome, most of the time, this hemolytic uremic syndrome are because of the complement thing. So you will not find any kind of, help with this steroids. Steroids can only prevent when there's sudden inflammation, and because of the sudden inflammation, there's hemolysis or some infection is there. So that steroid will help. But if there is complement pathway involved, steroid, what we will do? Steroid is just an anti-inflammatory, right? It cannot help with the, it cannot help against complement pathway, complement proteins. This is because there are antibodies to Adams TS13 in TTP. It is not the mechanism of HUS. So that's why we have seen this, especially there are antibodies to Adams TS. So in TTP, again, we have covered here that in TTP, this Adams TS is the one. A low level of ADAM-TS supports the diagnosis of TTP. So this ADAM-TS again is one of the complement protein. It's actually the antibodies complex which are actually low in TTP. So this will give you a clue. Whenever we have low levels of ADAM-TS, we can say that must be a reason of TTP. But just think about this one, that both of these things, whether it's a TTP or it's a hemolytic uremic syndrome, you will always find Prior to them, there will be infection of E. coli, there will be infection of Shigella, and upon those infection later on following, you will see the patient is going to bleed. There will be decreased platelet count. So
What here
decreased
TTP
platelet count,
stands for?
huh?
TTP stands for?
It's thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic, like decreased amount of platelets, and they will not be able to form a clot, and that's why bleeding will be there. So that is TTP.
So
And
H2S does not have anything to do with urine, huh?
sorry, come again.
Hemolytic uremic syndrome does not have anything to do with urine.
Hemolytic uremic, no. It has nothing related to urine. No, you may find hematuria because of the bleeding, intravascular hemolysis. The bleeding can be there. The child or the patient can present with hematuria. Of course, the presentation can be, but it has nothing related particularly with the urine. Of course not. It's only about hemolysis. It's only about intravascular hemolysis. It's only about decreased platelet count. Right? Try it. Just remember this. Try it. Renal insufficiency.
I need to make notes for these all.
Yeah. It needs continuous revision. Otherwise, you will be confused in TTP, Hus, and Hinoxian line.
Yeah.
Okay. So let's go to the questions. Here the question is saying a 2-year-old boy brought to the pediatric emergency department. The mother reports first the boy has become increasingly irritable. And then what will happen? Fever over the last 2 days. He has passed very little urine, so renal compromise, renal insufficiency, and his skin has become pale. The mother had consulted the pediatrician 2 weeks before because the baby had suffered from bloody diarrhea. Bloody diarrhea, vomiting, high fever. You remember, severe bloody diarrhea is always associated with shigellosis, always associated with Shigella infection. So the baby was having Shigella infection 2 weeks before. He was treated on that, and then later he's presenting with renal compromise. Symptomatic treatment with acetaminophen and probiotic had been started. Physical examination shows mild petechiae. So thrombocytopenic features is also there in the baby on the lower extremities. Urinalysis revealed microhematuria. It's showing hemolysis. So hemolysis, thrombocytopenic features are there, like petechiae are there, and then the very important thing here, the history of shigellosis, for which the baby was treated already, and now the baby is presenting with symptoms of hemolysis. The test results show low HP, of course. INR is okay. WBC count is raised because infection was there already in the body. Platelet counts are low. So platelet counts are low. That will give you a clue. MCV, it's okay, normal. MCHC is normal. RBC count, everything is normal. Prothrombin time is normal. APTT is normal. Why though both of them are normal? Because it's not a clotting factor deficiency. It's a platelet deficiency. So you will see only platelet count decreased. If clotting factors are deficient, then you will see only increased amount of PT and APTT. But if PT, APTT are normal, it means that clotting factors are absolutely normal in this baby. Now, which of the following is the most likely diagnosis? Based on the presentation of the Shigella infection later on.
Dr. Hira?
Yes, dear.
When PT and APTT are normal, then what will be raised?
Platelet, no one will be raised. With this PT and APTT normal, it means that clotting factors are normal.
Will be decreased?
Of course, it's a case of thrombocytopenia, na?
Yeah.
So platelet count will be decreased. That will give you a clue that it's a case of HUS or it's a case of PTP. But
so PT and APTT are increased only when there is deficiency in clotting factors. Huh?
Exactly, that occurs in HINOC. Exactly.
Not it had nothing to do with platelet count.
Yes, platelet count has nothing to do. Only platelet counts are decreased in terms of purpuras or idiopathic thrombocytopenic purpura, or here in case of thrombotic cytopenic purpura or HUS. But now what is the one clue which can give you a diagnosis that whether it's a HUS or whether it's a whether it's a TTP? So once you have seen the Shigella infection prior, like this one is mentioned here. So once the infectious history is there, always think about hemolytic uremic syndrome. So not the TTP. Once both are there, HUS and TTP, then how you're going to differentiate whether this is the case, because the presentation is almost similar. But only a one thing which you can easily differentiate, if there is a documented Shigella infection or something like that, infection is there in the question, always think about hemolytic uremic syndrome, right? Because for TTP, in order to make a diagnosis of TTP, you have to check Adams T level. You cannot say without checking this Adams T level. But in hemolytic, you just have to have this Shigella infection prior, the renal insufficiency is there, the platelet count should be decreased, right? So only these three things will help you in making a diagnosis of HUS. But in order to make a diagnosis of TTP, not only platelet count should be decreased, but of course the low levels of Adams TS, which is a complement protein. So you remember, so we cannot say here it's case of TTP because we don't have anything related to Adams TS complement proteins here. So it's a clear case of hemolytic uremic syndrome where it has
So
mentioned
for
Shigella.
ITP, Dr. Hira, for ITP, there will
ITP
be
is only
increase
idiopathic
level in
thrombocytopenic. Only
platelet count.
platelet counts will be decreased. Yeah, nothing will be much, like there will be no infection prior to this Shigella, and after Shigella infection there is renal compromise and platelet counts.
And in
Here,
TTP,
in TTP, there can be a history of Shigella or E. coli infection, and later on, of course, the same presentation, renal insufficiency, everything is there. But just in order to say this TTP, you have to have platelet counts low plus low levels of complement protein, that Adam TST3. Without that, you cannot say it's a case of TTP. Are you
okay.
getting me? So whenever there is low Adam TST3 complement protein, you will say it's a case of TTP. But only the
TTP,
presentations are there and Shigella
TTP
infection is there.
have we
Yeah.
done right now? TTP, we have it done right now, TTP?
TTP and HUS we did together, dear. We did together. It's together because it's the same thing. Only on the basis of diagnosis we will differ. It always come together because that's the same thing. Only in order to make a diagnosis of TTP, just memorize this line. A low Adam TS level support the diagnosis of TTP. That's the only clue. When you do this checking of this complement protein, if it's low, then you can say, okay, it's a TTP. It has nothing to do with the HUS. In hemolytic uremic syndrome, the level of Adam TS will be normal. Only platelet counts are decreased.
Actually, मैं बीच में 5 मिनट के लिए सो गई थी.
Okay, no problem. Actually, it's too much for the day. That's why.
It's evening and usually I take a nap at this time. That way.
Oh, okay. Only it's for today. Tomorrow we can do early in the morning, right? Tomorrow is Friday, so we'll do in the morning. Okay. So let's go to the next one. Okay. Then we have hydrocele. Hydrocele is a very small topic. 769. Small terms you need to memorize. So whenever we say hydrocele, it's a painless, solid, fluid-filled sac along the spermatic cord within the scrotum that transilluminates upon inspection. So it's just think about that inside within the scrotum along the spermatic cord, if there is a fluid-filled sac, and it's a fluid filled, nothing percent, nothing in there, only water is there, and once you turn on the torch and you just put the torch in front of this sac, you will see transillumination, like that is going to glow. So glowing of light is there, easily reflection is there. You can say it's a hydrocele only because it's watery filled. It is a remnant of tunica vaginalis and usually resolved within first 12 months of life. So this remnant, which is tunica vaginalis, has to be resolved within first 12 months of life, and it does not need to be reassessed unless present after 1 year. For most hydrocele, watchful waiting is the appropriate management. If the hydrocele persists beyond 12 months, surgery is recommended. So most of the time, when the baby is 1 year old, the hydrocele will get dissolved itself. You don't need to do anything. But if the baby is 1 year old enough and more than 1 year old and still the hydrocele is there, then you can think about surgery. You can easily remove this one, because if you don't remove this one, in the future, the baby may have chances to develop inguinal hernia. So think about any fluid-filled cavity who is there inside the scrotum, within the scrotum, along the side of spermatic cord, and that is actually the remnant of tunica vaginalis that has to be diminished, that has to be resolved within 1 year. And if it goes beyond 1 year, then we will just, what we will do? We will do surgery. Why we are doing surgery? Because we want to minimize the risk of inguinal hernias. And what is the basic examination point of this hydrocele? When you just turn on the torch and you put the light on it, it will trans-illuminate. So if the light can easily go through this this fluid-filled cavity and it will start glowing, you can say that's a hydrocele.
Excuse me, Dr. Hira, hydrocele is good in adults, no?
it's a 1 year old. In 1 year old till 1 year, it's a complication of baby boy who just born right now.
वो तो ये
Within
बड़ों
a-
को भी तो होता है ना.
no, it's not there in elderly people. If it's there in the elderly, we have to differentiate from varicocele. Let me show you varicocele also. Varicocele is what? Varicocele is a varicose vein in the scrotal vein causing swelling and increased pressure of the pepiniform plexus that just mimic like hydrocele. But what is actually there? It's a swelling and increased pressure of the plexus, pepiniform plexus inside the scrotum. The most common complaint is dull ache and heaviness in the scrotum. So बड़ों को ये varicocele होता है. They usually have this varicocele. But in children who are just born 1 year old, they have this hydrocele. So there's a difference between hydrocele and varicocele. Varicocele is actually the swelling of the vessels, pepiniform plexus, inside the scrotum. And here, this is the remnant, that is tunica vaginalis, who has fluid-filled cavity. But that has to be regressed, that has to be diminished, suppressed
Hydrocele
after 1
only
year.
develops in children, huh?
In children, up to 1 year of
Okay.
age. And beyond that, you have to do surgery in order to get rid of this problem. But this
Adults
varicocele
always
can
have
happen.
varicoses, huh?
Adults have varicocele, yes, where there's the inflammation of the pepiniform plexus. It can
They will
happen in
always have
children also.
varicocele. Never have
Yeah.
hydrocele.
Adults cannot have hydrocele. Right? It's not a disease of adults. It's just a disease of 1 year old child. Beyond 1 year, it should not go. It should be removed. So it cannot be happen in the adults, right? So varicocele is the most common cause of scrotal enlargement in adult males. Now, best initial diagnostic is proper physical examination. Of course, the bag of worm sensation, they usually have this thing. For your exam point of view, they will say the bag of worm sensation, the most accurate test. Of course, you will go for the ultrasound. You will see the vessels are dilated there. So you will go only for the ultrasound. This is also a problem of testes, cryptorchidism. What will happen here is the congenital absence of one testicle in the scrotal sac. So the scrotum, which has one sac but has two testes. But if it has only one testes, we can say it's cryptorchidism. The missing testicle is usually where? You can find that testicle anywhere in the inguinal canal or maybe in the abdomen. And of course, in the baby boy also, the testes are inside the lower abdomen. And as soon as the baby delivery of the baby boy, the testes has to be descended soon after delivery of the baby. But what if one is remained there inside the abdomen? It has to come down within 1 or 2 years. If it's not there, we have to go for the surgical option. Otherwise, it can cause tumor. It can cause, that will be very lethal to the baby. So after 4 months of age, orthopexy of congenital undescended testes is recommended as soon as possible, and the surgery should be definitely completed by 2 years of age. So you should not go beyond 2 years of age if you already found that the testes, one testes is in the scrotum and one testis is in the inguinal canal or maybe in the lower abdomen. That has to come down. So 2 years is the deadline. After 2 years, you have to remove that testis. Otherwise, if you keep on remaining that testis there in the abdomen or in the inguinal canal, what will happen? That will become incarcerated. And it can cause tumor or a lethal effect to the baby. So increased risk of malignancy if you keep on letting there, maybe in the lower part of the abdomen or inguinal canal. It has to be inside the scrotum. So you can wait only up to 2 years. After that, you have to go for the surgery. Okay, so let's go to the question. Question we have only related to hydrocele. A newborn boy. See, a newborn boy is brought to the pediatric clinic for a checkup. Examination shows a tense, fluctuant, painless mass on the right side of the scrotum, shining a bright light. It's a light, not bright. Bright light toward the enlarged right side of the scrotum by torch. Clear. I hate this whole CR, too much spelling mistake. A clear illumination is observed. Now, which of the following is the most likely diagnosis? So, see, it's a fluid-filled cavity. It's a painless mass in one side of the baby, or especially a newborn baby. Whenever it says newborn baby, always think about hydrocele. And the important examination finding is when you put the torch on, you will see trans-elimination. So, if trans-elimination is there, it's a clear, confirmed fluid-filled cavity. It's a hydrocele. So, we go for hydrocele. Then we will go for Turner syndrome and Down syndrome. 2 topics are remaining. Down syndrome will cover from AMBERS because it's not there in MTB. Turner syndrome also is not there in MTB. So Down syndrome, it's a trisomy 21 where you can see one extra chromosome. So you will see normally we have a duplicate like pair of chromosome, but in trisomy there is triplet. So three things are there. Is trisomy the most common autosomal chromosomal irregularity occurring approximately 1:700 live birth. The risk of trisomy 21 pregnancy increases with maternal age. So if the maternal age is high, think about the chances of getting babies with Down syndrome will be high. And most individuals with Down syndrome have full trisomy 21, which occurs due to meiotic non-disjunction. What is there? Instead of one complete copy of chromosome 21 and a total of 47 chromosomes, so one extra chromosome. So it's a disease of one extra chromosome. Trisomy, triplet, one triplet. So not we have 46 chromosomes, but one extra means these babies will have 47 chromosomes. And what is there when they have this 47 chromosomes? So we will see that these babies are clinically going to represent what? They are having upward slanting palpebral fissures. So you can easily diagnose Down syndrome babies just on their presentation. But still they have certain other things like epicanthal folds, protruding tongue, short stature, single palmar crease. You will appreciate in these babies. They have heart defects as well. Duodenal atresia can be there. Hispanic disease. They are more prone towards getting infection. Endocrinal disorders you can also find in these babies. Of course, it's a syndrome. Syndrome is a collection of abnormal diseases which you can easily find in these babies. So what you can do, you can just do karyotyping. So that's why Down syndrome screening is usually done. Usually we can see on 11 weeks anti-scan, and anomaly scan also we can easily find out. So that the mother has to know right from the beginning the baby is going to suffer with this one, and it's totally a decision of mother to carry the baby. Of course, this baby is life is not in a threatened condition. Of course, it's compatible with the life. So that's why we never recommend the mothers to go for this medical abortion. Anyhow, it's up to the mother whether they want to carry or not. We have to tell all these trisomies or syndromic babies early in the anti-scan. Whenever they are detected on the anti-scan, you have to counsel the mother regarding those, and then the decision is totally dependent on parents whether they want to continue the pregnancy or not. So important features, clinical features, how these babies are going to present. So these are very important for our exam point of view also, because you can easily differentiate on the basis of symptoms they are going to present, like upward slanting fissures are there, epicanthal folds are very prominent in these babies. They are having brush-filled spots, which are actually what? When you do the periphery checkup of the iris, you will see aggregation of connective tissue. That's the brush-filled spots. They are very common in these babies. Let me go back. What is happening? Mouth, you will see a small oral cavity together with a large and furrowed tongue. So big tongue, which is always protruding out. See, you can easily differentiate on the basis of their clinical features. Teeth, you will see late development. Other features, brachycephaly can be there. In brachycephaly, what you will see, a head shape anomaly caused by premature fusion of coronal stitches. So their hands are not properly well developed in these babies. You can find ear anomalies also, very low sets ears in these babies. Short neck, they may have short neck. Excess skin at the nape of the neck may be seen in prenatal ultrasound. So that will give you a clue on ultrasound. But anyhow, ultrasound can easily detect, NT-scan can detect these type of anomalies. So you can just go over these things. I'm not going into the detail of this one, but for only our exam point of view, you should know that it's a 47 chromosome. It's a trisomy condition. Most importantly, the symptoms, of course. Now, how we are going to treat these patients? Of course, we have to provide them supportive therapy. We cannot do this one because it's a chromosomal abnormality. So we can just provide them if they have a difficulty in speech, we can provide them speech therapy, behavioral therapy, physical therapy. So only supportive treatment, nothing else we can do in these babies. So if you look at the question here, you can easily get an idea from the question. A newborn present with a low weight and hypertonia, tongue protrusion was observed on multiple occasions. So tongue protrusion is one of the main features, has a single palmar crease, again one of the most important clue. Cardiac auscultation, you will find systolic murmur and echocardiography confirm the VSD, ventricular septal defect. So VSD is highly associated with these Down syndrome. So VSD is there, single palmar crease, tongue is protruded. So based on all the symptoms, you can say it's most likely a Down syndrome. And if they have mentioned the chromosome and chromosomal amount, that will directly give you a clue. Anyhow, single palmar crease, tongue protrusion, and VSD, three main important features are there in order to make a diagnosis of Down syndrome. Then we have this Turner syndrome. Turner syndrome is actually a female disease and Klinefelter is a male disease. Let me pull this one. In Turner syndrome, we have one X which is deficient in these females. So usually we have this 46XX, but here you will find the number of chromosomes is usually monosomal. You will see one deficient chromosome. So one X is deficient here, 45XO, and no bar body. So you may find this one. In sex chromosomal mosaicism, sometimes you can find mild phenotypic expression, means sometimes it's the presentation may be like this one, 45XO, or sometimes it can be 46XX, but there is mild mitotic, you can say mild disjunction, means that sometimes it's okay, the presentation is like Turner syndrome, but when you do the examination you will find 46XX. So it's a normal female, 46XX, but based on the mild disjunction, some properties here and there will be just mimicking like a Turner syndrome. But remember, most of the time Turner syndrome having the chromosome number 45XO, one X is deficient here. So phenotypically, the patient is going to be a female, of course, but you will find some problems here like delayed puberty, primary amenorrhea, infertility in these. They are having webbed neck. That's a very common feature of these, and short stature, obese, webbed neck, of course, infertile, primary amenorrhea, delayed puberty. So these are very, very important features in these Turner syndrome patient. And important of all, you should know the chromosome amount, 45XO. You will see web neck in this patient. Osteoporosis, of course, is going to be much in there. They are infertile in their life. They are having coarctation of aorta and bicuspid aortic valve, not VSD. The VSD feature was with Down syndrome. Okay, must remember this one. Then, of course, type 2 diabetes mellitus, they are very prone towards having this type 2 diabetes mellitus. Hashimoto thyroiditis can be occurring in this one, but that's an association. But most of the females, they are going to have this type 2 diabetes. How you're going to treat this one? Because it's an X chromosomal X deficiency. So we have to provide an estrogen progesterone. If there is too much infertility, primary amenorrhea is there. If growth hormones are severely deficient, growth is severely impaired, you can go for the growth hormone. And if there is surgically more of streak gonads, if the streak gonads are there, like ovaries are there, but they are very, very much small or necrosed, you can just remove that. Or sometimes they are having this hypergonadotrophic hypogonadism. What does it mean? Hypergonadotrophic means you will see FSH LH increase, but hypogonadism means this estrogen androgen will be less, but increased amount of FSH LH. So if there is too much LH and estrogen is not there, that's why the fertility is not there, right? Because estrogen and progesterone and androgens are the one who are responsible for maintaining the vascularity and muscularity of the uterus. They are the one who will help in pregnancy or in fertility. But these increased FSH and LH if are raised, then what will happen? Ovulation can be there, but there will be no effect on the uterus. So they are not fertile at all. So you will see this hypergonadotrophic, like increased FSH LH, but hypogonadism, this estrogen and androgen will be less. So ovaries will not work properly.
Excuse me, Dr. Hira. What is the role of prolactin in this? It is not relevant. This is not relevant the question with regarding to this our topic. But what is the role of prolactin in this normal menstrual cycle, in this cycle?
Yes, when we say once the menstrual cycle starts, right? Usually we have this Mullerian hormone, which is under the control of this prolactin hormone. That's why the girls beyond 13 years of age or 12 years, 11 years of age, they don't have this phenomenon of menses. So there is one of the hormone which is responsible, anti-Mullerian hormone, and that is under the control of prolactin. This prolactin is released from, of course, from the anterior pituitary. And the main function of this one is to keep the level of this anti-Mullerian hormone down. So there will be no phenomena of menstruation at all. But once the puberty is achieved, this prolactin starts to work. But if there is too much amount of prolactin, then what will happen? If there is too much prolactinemia, then what will happen? We will see that the main function of prolactin is not only related to the formation of milk, but of course, when there will be too much amount of protein, what will happen? You will find what will happen actually? This prolactin can raise the amount of LH and FSH, and they will decrease estrogen and progesterone. Because once the baby is there, once the baby is delivered, that's soon after the delivery of the baby, this prolactin and oxytocin, they are responsible for, for the feeding or for the colostrum formation, or all the galactoria will be there, the natural galactoria, the breast milk formation. It totally depends on that. So think about this one. The one who has delivered, it's now having this increased breastfeeding, right? Increased amount of milk production and everything, galactoria. But that's because of the delivery of the baby, right? So what will happen in especially in those where the prolactins are high, a part of this delivery system and all that, the one who is having normal delivery, they are in the phase of lactational amenorrhea, right? So what is the physiology behind lactational amenorrhea? Behind lactational amenorrhea, there will be too much LH and FSH, but there will decrease estrogen and progesterone. That is the function of prolactin. Prolactin is going to maintain the whole lactational amenorrhea findings in a woman who just delivered a baby. That's a normal scenario. But what happens if it's happening in the girls, or the one who has not undergone the normal delivery? Then they also have the same phenomena. They will have increased production of this breast milk without having a baby and all, without delivering a baby, and the increased amount of LH and FSH, and there will be no fertility at all. They are not going to get menses. They are not going to produce babies. Why? Because they are in a state of this lactational amenorrhea. That's a function of prolactin. Are you getting me? Because the normal function of the prolactin is to maintain maintain only, not only maintenance of this, breastfeeding and all that, milk production, but to keep the whole body of the female in a way that now the mother is infertile. Now this time period, the mother cannot produce estrogen, progesterone. The mother cannot have cannot undergo the formation of fertilization again, cannot be a fertile at that time period. That's why it's called lactational amenorrhea. Those who are breastfeeding, their prolactin is working very good. They are in the phase of lactational amenorrhea. They don't even need any kind of contraception if they are feeding properly, right? But think about the one in the girls, or where there's a disorder, where there is too much amount of prolactin because of the tumor in the pituitary, or maybe some other pathology, because of that prolactin is very high. So the whole body is in the state where there will be infertility. Thinking about lactational amenorrhea, there will be galactoria.
But if we see the algorithm or this feedback, if FSH and LH is high, they will not stimulate ovaries to produce more estrogens and this ovulatory cycle and this ovulation.
Because prolactin is there, na? Prolactin is going to inhibit that. Prolactin has an inhibitory effect on LH and FSH when it comes to stimulating the ovaries. And this estrogen and progesterone is not going to release just because of increased level of LH. Of course, LH is increased. There will be LH surge. There will be ovulation. But once the fertilization is there, then that corpus luteum is responsible to release progesterone and estrogen. That's not the increased level of LH who is responsible only. You cannot say it's not the whole sole function of LH to increase estrogen and progesterone. That's the function of corpus luteum, who is releasing hormones under the influence of fertilized egg. Are you getting me?
Yes, yes.
Yeah. So LH is only responsible for the ovulation. Like ova is going to release, but that ova is fertilized. When fertilization is there, corpus luteum is there, then only the estrogen and progesterone will be released. But till then, the prolactin is having an inhibitory effect on that one, once the mother has delivered recently. But if it's happening in any way, in other way around, like in a normal female, like
I'm talking about a non-pregnant woman.
Yeah. So in non-pregnant, because there is no corpus luteum, there is no estrogen, progesterone. And there will be too much amount. If there is too much amount of prolactin because of pituitary tumor, because too much amount of prolactin is not normal, right?
Too much of prolactin will increase in production of FSH and LH, and they will inhibit production of estrogen and androgens, huh?
Exactly. Whatever that there, not only from the corpus luteum, but those who are releasing from the adrenal gland, they are going to inhibit those, in fact. Yes, they are going to act on those.
Okay. Thank you very much.
So let's have a look at the Turner syndrome here. A 19-year-old girl present with a short stature. Now, girl with a short stature, wide space nipples, and primary amenorrhea. So think about primary amenorrhea. There should be more symptom like web neck, or maybe aortic stenosis, or some findings can be more there. But it's quite clear, a girl with a short stature, with wide space nipples, with primary amenorrhea, What is the most likely karyotype? So karyotype should be 45XO. Simple question. Which of the following finding would support a diagnosis of Turner? What do you think? Which of the following would say that this is a Turner baby? A palpable liver, who's having a palpable liver 2 centimeter below, or who's having redundant skin folds at the nape of the neck? That is called webbed neck. That is the feature. Hypertonia and ankle clonus, it's nothing like that. Single palmatees will be in the Down syndrome, not in the Turner. So this webbed neck, that's another name is redundant skin fold at the nape of the neck. That's actually a webbed neck, and webbed neck is a feature of Turner syndrome. Short stature, webbed neck, 45XO, these three.
Dr. Hira, again, we just studied it. It will be present in Downs too.
In Down syndrome also, yes. But in Down syndrome, of course, you have to have 47 chromosome, you have to have single palmatory, VSD can be there. The baby is totally, the presentation is totally different. But they're also
I know. Just asking for them.
Yeah. But based on these findings, you have clearly web neck, so you can go for Turner. If they're asking for the Down syndrome, then we have this space neck also, and single palmatories too will be there. Yeah. Now, 13-year-old girl present to the clinic for an assessment of a short stature. So short stature girl, the patient has a height and is below the 5th percentile, web neck, so third feature, lack of breast bud development. So you can think about this one, secondary sexual characters, high arch palate and low set posterior hairline. Which of the following is the most likely diagnosis? So based on all these findings, short stature girl, web neck, high arch palate, it's okay, and this low set posterior hairline, breast bud development, lack of breast bud development. So this will give you a clue of Turner syndrome. Okay, this one, a 15-year-old girl present to the clinic with her mother. The mother is concerned because she has never menstruated. Primary amenorrhea. Think about primary amenorrhea. Whenever the question says never menstruated, the mother is worried about her baby. So that's a primary amenorrhea. On examination, the child has a short stature, short neck with a low hairline, hypertension. Her parent's stature is below average. So here also the parent stature is below average. So it can be a constitutional delay also, right? But again, which of the following is the most likely diagnosis? If we have constitutional delay, you can think about that. But the mother is concerned because on a child has short stature, but because short neck is there, you can think about that neck, you can think about short stature, you can think about girl with primary amenorrhea. So constitutional delay will be less likely. In constitutional delay, everything should be normal. There should not be a short stature, there should not be a web neck. Only the thing is that the age of the girl is 15, 16, and right now she's not menstruating. That is called constitutional delay. In there, we can have a thing in our mind that the parents might be having this familial short stature as well. That's why now here if it's mentioned her parent stature is below average, you can think about familial short stature as well. But why you're not choosing this option? Because not only because of short stature, here she's primary amenorrheic as well. Those babies who are having this familial short stature, they have nothing to do with the primary amenorrhea. They menstruate on their own time. But if it's saying primary amenorrhea with the short stature, with the web neck, then you will think about Turner syndrome. You're getting me? There is only one point which is going to segregate that whether it's a constitutional delay or a familial short stature. In constitutional delay, there will be no short stature, there will be no web neck. Only the thing is that the girl is having age of 15, 16, and yet she's not menstruating. Then you can choose constitutional delay. If it says familial short stature, everything should be normal. Primary amenorrhea will not be there. The patient should be fertile and everything is okay. The only thing is stature is short. The height is shortened. Then you will choose familial short stature. But whenever it says short stature, web neck, and primary amenorrhea, then it will give you a clue of Turner syndrome. Okay. So thank you so much. I know today it's too much saturated, too much topics to cover, but I hope if you go through the recording again, it will help you. So thank you so much. Thank you everyone for joining. Most of them already left. So let me stop the recording. Thank you. Bye everyone.
Bye bye.